take a roll call of the membership for the minute of the meeting, and I would ask that members confirm they are present when I call their name. Councillor Lynn.
Present.
Thank you very much. And I know that Pat Kilpatrick has submitted her apologies, and I believe that Jenny Alexander is attending as her proxy. Is Jenny Alexander present?
Present.
Thank you very much. Councillor Toland.
Here.
Thank you. Councillor McHugh.
Present.
Thank you. And I've got apologies from Anne Buchanan. Donald McPherson.
I'm present, Willie. Sorry, can I also just mention, I did receive a note from Pat saying that she was going to try to attend this meeting. So can I maybe suggest that Jenny is recorded as proxy for Anne Buchanan, who I know is not able to attend? I hope that's okay, Chair.
Yeah, when did you receive that? Because I spoke to Pat yesterday afternoon and she wasn't coming at that point.
Or, okay, well, maybe your information supersedes mine. I think it was Monday evening.
She was trying to come, but yeah, okay. The proxy is Jenny.
Thank you.
Yeah, thanks very much. Diane McCulloch. Diane McCulloch present.
Yes, good present, Willie. Apologies.
Thank you. And Vicky Irons.
Yeah, present, Willie.
Dave Berry.
Present.
Dr. David Wilson.
Yeah, present, Willie, thanks.
Sarah Dickey.
Present.
Dr. James Cotton. Dr. Cotton. Markham is absent. Raymond Marshall.
Yeah, here, Willie, thanks.
Jim McFarlane.
Yeah, here, Willie.
Christina Cooper. Mark Graham is absent at present. Martin Sloan.
Present.
Dr. Fletcher.
Present, thanks.
And Dr. Shaw.
Present.
Okay, thanks very much. That concludes the roll call. And we've covered up apologies for absence. As well, not any members of any declaration of interest in the content of the agenda as it stands. And there being no declarations, it was taken on to item 3, which is membership and chairperson. And the new membership from Dundee City Council is there before you for noting, as indeed the proxy members are listed also. And you've also been appointed as chairperson by the council. Those points are for noting. It takes you on to the membership of the Performance and Audit Committee.
One second, please, Willie.
Yeah,
I'd just like to take the opportunity, given the nature of this item, to welcome the new members of the IJB. You've just mentioned the names, Councillor Siobhan Toland and Councillor Dorothy McHugh. Welcome aboard, and I look forward to your contributions over the length of the time that you serve on the IJB. I'd also like to give thanks to those who are no longer with us, although Helen was a minute ago, and that's Bailey Wright, Councillor Lynn Short and Councillor Roshan Smith, who previously served on the IJB. So my thanks to them and my welcome. Thanks, Will.
Okay, thank you very much. Item 4 then before you is membership of the Performance and Audit Committee. And we're asked to note that effectively the membership of the Performance and Audit Committee from Dundee City Council would be Councillor Siobhan Toland and Councillor Dorothy McHugh, as they don't hold the positions of chair or vice chairperson of the Dundee IJB. That's for noting. It takes you on to standing orders, and you're asked to agree to accept and adopt the current standing orders for the Integration Joint Board.
Yes, before I open this one up, I actually have a question. I think it's at 2.6 in the new standing orders, or, well, most of it's not new, but sorry, I'm just getting to this. I think it's 2. So yeah, I would maybe Mr. Meny could give me some guidance on this. It's at 2.6 in the standing orders, where it says a voting member appointed under paragraph 2.1 ceases to be a member of the IJB if they cease to be a councillor, etc. I'm wondering if I actually, the way I read that, did I cease to be a member of the IJB? Given that, as far as I'm aware, I didn't cease to be a councillor. I wonder if Mr. Many could give an opinion on that, if he's here. And I don't think he is. So that's something I'll take up with Mr. Many out with the meeting. Does anyone have any questions or comments on the standing orders? Pretty straightforward, really. Yeah, Dorothy.
Before I ask the question, do we just put our hand up if we want to ask a question at this meeting?
Yes,
Is that
if you could use the hands up function on the
right?
Yeah, I think everyone's able to do that.
Okay.
Yeah.
I just wanted to ask, as a new member, I haven't seen the standing orders before. Are these new? Are there changes to these standing orders? Are they significant?
Is Mr. Many here? No.
Chair, I can confirm that these are the current standing orders for the Integration Joint Board. Yeah. They're simply continuing on to the new membership, and we're agreeing that these be adopted. Yeah.
Okay,
Yeah,
thank you.
Nothing new from the last 4 years. Jenny Alexander.
Yeah, thanks, Chair. It's paragraph 2.3. While I recognise that that's always been in, I just want to point out that doesn't actually take into cognizance the role of an employee director within the NHST side, because the maximum of 3 years that we can stand for as many years as we're always elected.
Yeah, this just refers to the Integration Joint Board. It doesn't refer to any reference to your appointment with NHST side.
Yeah, I get that. I get that, but it's the same for anybody. You can hold office more than 3 years. You can be re-elected to the NHS board, but that paragraph then means that you can only do 3 years on the Dundee, for an example, on the Dundee IJB.
I will need to take that up with Mr. Many out with the meeting. Can you minute that, please, Willie?
Yeah, thanks very much. Chair, we'll do that.
Thank you.
If you're,
Thanks,
if you're
Chair.
happy to agree with those standing orders, it takes you on then to, if you're happy to agree, it takes you on to item 6, is the minute of the previous meeting of 20th of April, which is submitted for approval.
Yeah. Can we just go through this page by page? If anyone has any issues, can they raise them? If there's any inaccuracy or point they wish to make, once I get to it, that is. Yeah, so first page, page 1, page 2, page 3.
Sorry, Chair, I have a comment on page 2.
Yep.
And it relates to the Clinical Care and Professional Governance report, Roman 5. I raised a point under discussion of that item. I asked that this report, or somewhere we should receive a report on compliance with the MAT standards. And I did ask for that to be captured as an action at the previous meeting. And I don't see it either in the minutes or indeed in the action tracker. So again, I would ask that we receive reporting of how we're doing against the MAT standards. Whether the clinical care and professional governance report is the right place or not, I'm open to discussion, but I do believe that should be visible to us.
Yeah, can we have that added to the minute of the previous meeting, please? Thank you, Donald.
Thank you very much.
On page 3, page 4, page 5, page 6, page 7, and page 8. Well, nobody's going to disagree with page 8 if there's nothing on it.
Okay, thanks very much then, Chair. With that item having been agreed, it takes you on to the action tracker, which is simply for noting at this moment in time, and the actions from the previous meeting will be updated to that to take account of the point which the Donald has raised.
Any comments on the action tracker? Don't see any. Next item, please.
Thanks very much. Chair takes you on to item 7, the Community Custody Unit Report, at page 25, and this is for noting.
Second.
Chair, I'm happy to introduce that, if that's okay.
Yeah, I'm just trying to find the report. I've got it now. Yeah, can you go ahead, Diane, please?
25, yeah. I do have colleagues on the call. So Martin Day, who is our service manager for community justice services and care leavers in Dundee City Council, and also Angela Cunningham, who's our justice healthcare manager with Perth and Kinross Partnership, and they're absolutely the experts in this field. But just to introduce the paper, people will be aware that there's a community custody unit for women that's going to be opening up in Dundee very shortly. It's the first of its kind in Scotland, and really seen as an initiative in the way that we support women in the prison service, brings the services that we deliver much closer to the communities that people come from, or as close to the types of communities that they come from as possible. One of the reasons for bringing this paper was in previous IJBs, we have been asked about how the Dundee Health and Social Care Partnership will interface with this unit, and really just to get a sense of how both health and social care support will be provided. In reality, the health support in terms of people in the unit will actually be provided by Tayside Prison Healthcare, which Angela heads up on behalf. It's a hosted service in Tayside and works currently across prisons. So they will provide the healthcare in prison support in regards to the service, and Martin's staff will support people as part of their transition coming out of prison and looking to see what they need in terms of support. This unit, which is going to be called the Bella unit, is based in Coleside area, and there's been really good connections with communities to try and ensure that people are comfortable with the service which is being provided. But from a Dundee Health and Social Care Partnership, because there'll be people coming from all over Scotland, initially potentially, but mostly from Tayside and Fife areas as we move forward, our role will actually be supporting those women that are Dundee women that happen to be coming back into the community through this route rather than perhaps any other routes. So we don't anticipate from a Dundee point of view that there'll be excessive support that we will require to be putting into the unit, but absolutely supporting the women from our area to transition back to their communities and to their life in the most positive and supported way that we can. So I'm going to stop there, but Angela and Martin are happy to answer any questions that people may have in regards to the detail of that.
Yeah, I'm really pleased to see this coming to Dundee, Diane, and I think it'll be particularly helpful for women from Dundee to serve the latter part of their sentence in a community environment in their home city of Dundee, having access to family members and the services that they'll be using once they are finally released. So very, very welcome. Kind of a shame that Bailey Wright didn't stay for this item, given the amount of enthusiasm that she showed, not only for this project, but for the welfare of prisoners over many years. I'm missing Helen already, as you can see. Yeah. So does anyone have any questions on this unit, which will be opening soon?
Lindsay, okay then, briefly.
Yeah, Dorothy. Dorothy McHugh.
Dad, okay. Lindsay.
Thank you. Yes, I echo your comments, Ken. This is an excellent initiative, and well done to Helen and everyone else who was involved in setting it up. Could I refer to section 4.2.3, where it says that within Dundee, where women were known to services prior to their custodial sentence, we will continue their health or social care support on discharge. Can I ask, maybe this is a question for Martin, what monitoring will be done to ensure that none of these women fall through the gaps?
You able to answer that, Martin? Martin Day?
Yeah, sure.
Yeah.
I'll try and answer from the social work point of view, and I think it's probably a health question as well. There will be much closer links with, and there's enhanced staffing within the community custody unit. Both SPS have got extra staffing and extra staffing for liaison. If it's a question of women moving from prison healthcare to, for example, to DDARS. I'm sure there will be advanced negotiation through their preparation for release, and then there'll be support after they are. Much of this is in place already for anybody in prison, but it will be even more intensely focused within a small unit like the community custody unit, where there is actually extra. At the start of this process, the SPS and the Scottish Government said there's no new women in the system, and that they tried to resist extra funding. But eventually the argument was won that this is a special model, this is an enhanced level of care. So I'm very confident that there'll be transition support both pre-release and afterwards. And actually there's extra staffing and extra funding to achieve that. So that would be my answer. But Angela probably has a stronger answer about the health side.
Thanks, Martin. Yes, certainly from the health side. Obviously, our prison healthcare staff work across the 2 prisons that we already have in Tayside and have the experience in people being liberated from prison. The great thing about the CCU is it will be in Dundee, so those links will be made with community services before the women are liberated. So we hope to have other services coming in to meet with the women, so they have their familiarisation visits and things, such as the substance use services, mental health services, and even looking into how we get the women into the primary care services. You know, if they show an interest in a practice, how can we actually get them ready to be registered for that practice immediately on release? It's a really exciting, fantastic concept, because we can do things differently that we can't do currently in the Melly state that we've got in Tayside. So we'll be learning a lot as we go along. But absolutely, the gaps, the numbers are small. The numbers of women that we're going to be having are small. So I really don't see any gaps or women falling through the gaps. All those links will be made prior to them leaving. There will be less of some of the issues that we have in the Mail estate at the moment, is perhaps when people are liberated from court, and that's where there can potentially be a gap in the linking up with community services, because it wasn't a planned liberation. They should all be planned, so it should not be an issue.
Thank you.
Ken, you're on mute.
Yeah.
Put myself on mute to cough. I didn't assault your ears with that. What was I saying? Yeah, the fact that it's geographically located in Dundee, I think, will mean, as I already said, that women will be able to forge strong links, or reforge strong links in the community. There's no reason to think that wouldn't continue post release. Donald, your hand was actually up first, but I took Dorothy first because she's new. So.
Nope, that's fair enough. Thank you, Chair. Thank you, Ken. I had 2 questions, if I can. I agree with what others have already said. I think this is a really important development, and it's good to see that we're going to be the first unit of its kind in Scotland. So my first question is, to some extent, this is a trial of sorts, and I wonder, what do we take as the measures of success of this exercise, and how will they be reported back to us? So that was my first question. The second one was around, and Diane touched on it in her introduction, but if you read paragraph 4.1.2, it talks about this being, well, it's in Dundee City, but it's priority provided to women from Tayside and North Fife areas where possible. Now, if I'm literal when I read these words, the assumption from that would be that this could also be a unit that accommodates women from outside Tayside and North Fife, and which is fine, but it sort of goes against the whole principle of being close to your family and your community if we have someone from Glasgow or Inverness staying at the unit. So I couldn't quite reconcile that. So that was my second point. Maybe if you could explain that a little. Thank you.
I think Angela would like to come in to answer some of that, and between Martin and I, we could always cover any of the other parts. But Angela, would you start, please?
Yeah, thanks, Diane. In relation to your second question, yes, it would be preferable that the women would be from Dundee and Fife. The reason that it's been opened up wider is because of the reduction of women in the justice system at the moment, who are in custody at the moment, who would be eligible for transfer to a CCU. The women from Dundee and Fife will be, who are eligible, will be offered a chance to come to Dundee. They won't be put to the Glasgow Centre, for example, when it's opened. They will be coming there. The where possible is it being filled with Dundee and Fife women, but it's unlikely that there will be enough women meeting the criteria, because there's been a vast reduction in short-term women on short-term sentences in custody at the moment. A huge rise in the number of people on remand, but we will only be taking people who have been convicted and have gone through a period of assessment prior to coming to the unit.
Yeah. Thanks for that.
Can I just come back on that point? Because I think my concern is still that, again, having people from out with Tayside and North East Fife coming into the unit, is there not a risk that that will undermine the way the unit works? Because these will be people who, by definition, are not within their own family and community circle.
Absolutely. The SPS plans in the beginning were to have, I think they were to have 5 CCUs across Scotland. And at the time when this was being pulled together, there were enough women in the system to have this amount of community custody units, but there just aren't the women in the system just now. So they'll be given the choice whether they want to come and have that. So they'll still have the community access, but obviously they won't have the community access in Dundee. And I think they will probably start looking at home leaves, similar to what happens in Castle Huntly. So they can actually go home for a week at a time. But that hasn't been confirmed yet. I haven't had that confirmed. I can't see them not being able to do that, because if we've got women, obviously, that are not just from the local area, where they're able to go and meet with the local services, then something different will have to be done to get them that access within their own local areas. We could be taking women from Glasgow in the beginning, because the Glasgow Centre will open, and it will just be essentially to make sure we have enough women in the unit to make it viable.
Okay. Yeah, on Donald's other point about how do we measure success, is it as simple as reoffending, or is it, and should it be more than that?
The Scottish Government have asked for a full evaluation of this, and they will be looking for figures. Most of that will be coming from Scottish Prison Service. I'm not entirely sure what that looks like at the moment, but there will be a comprehensive evaluation and ongoing monitoring, because this is the first of its kind in the world. Actually, there's the eyes of the world are looking at us to see how this is working. There's not been this kind of unit where we have quite so much community access, or unescorted community access. So it will be I'll be under a huge amount of scrutiny locally as well as nationally, internationally.
Yeah.
Yeah, go ahead.
I'm sorry to be argumentative, Chair, but I mean, that does all that you've said, Angela, not underline the fact that we should know today what will be the measures of success at the end of the project?
Chair, I wonder if I could come in. Would that be okay? Donald, we had hoped that Scottish Prison Service would be able to be here today, because probably that most likely sits with them in terms of the answer. So John, whose second name has gone from my mind just at this moment, unfortunately couldn't make it this morning, but did offer to come back and do an input into the model and the approach that is being taken. This is primarily led by Scottish Prison Service, with us feeding in similar to the way that we would with other kind of prison pathways. So I think that might be a question. Forgive me for cutting in, Donald, but I think that's probably a question for them. And I'm happy to take that off the table with Martin and Angela's support and see if we can get something pulled together for you. Obviously, we understand our bit of it, but that's quite a comprehensive aspect in terms of the whole pathway from a Scottish prison being the organisation that leads on that.
Yeah, happy with that. Thank you, Diane.
Sorry, Diane, if I could just come in, we will obviously be having, we have our own governance processes around healthcare, and we will be taking healthcare measures such as our waiting times and things through our normal governance process. We have a regular business and governance group that goes up via Perth and Kinross, clinical care governance group, and then laterally up to the board, to the IJB.
There's a lot of background noise somewhere. I'm not sure. Is everyone muted? Oh, there's no background noise now, so whoever it was has muted themselves. Next up and last but not least is Raymond Marshall.
Thanks, Chair. Thanks, I mean, I suppose my question was around how confident is there in staffing this unit, given all the staffing problems that we've got across not just Dundee but the whole Tayside, and how confident you are that you're going to be staffing it. And I think it would be good to see an update report coming back around the successes and how you've measured it. Thanks, Kim.
Okay, anyone like to comment on that?
If I could come in from a healthcare perspective, what we've done, Raymond, the healthcare model that we've looked at is rather than recruiting to staff specifically for the CCU, given the small numbers and the small numbers of staff we'll need for that, and the challenges that could bring when it comes to annual leave and sickness, etc. We have enhanced our prison healthcare staff, and we plan to rotate through the CCU and HMP Perth and Castle Huntly. We have recruited to the additional staff now, so it's not looking like being an issue for us at the moment.
Yeah, and let's look at this. Martin, your hands up as well. Martin, Dave, would you like to come in?
Yeah, sure. Social workers recruited to the social work post. I suppose the slightly robbing Peter to pay Paul, the successful candidate was a Dundee City Council social worker in the Children's Services, so the loss is there, but that post attracted somebody, certainly. Yeah,
this is I mean, I actually didn't know this was a world first. I knew it was first in Scotland, Angela. So there's a lot of prestige attached to this. The Bella Centre, is it? Or I forgot the name. A lot of prestige attached to this. So you would think that it would kind of look like be quite an interesting opportunity for a lot of people to work there. You'd hope that would mitigate some of the problems that we have elsewhere in attracting people to the workforce. So, yeah, and Raymond asked if we can have a report back, and I certainly welcome that. I'm very interested to see how the Bella Centre progresses and how the lives of the women who are resident there are improved over the medium to long term. So that is the end of that item. Thanks for your contributions. Next up, we have Willie.
Yeah, thanks very much, Chair. I recognise that item's been noted, and item 8 then before is reducing harm associated with drug use, and you're asked to agree the recommendations.
Yeah. It's tough to get this. This is on, sorry, 1 second, it's on another. I had intended to get in the office to get the paper copy because it's a bit easier when you're chairing a meeting, but unfortunately I didn't make it yesterday. Sorry for the delay, such an important item. Yeah, got it. Sorry about the delay there. Yeah, I think there are a few items on this agenda, or indeed on any future agenda, which are more important than our response to harm associated with drug use and drug deaths. I think, as everyone knows, Dundee's record going back for decades is shocking in terms of drug use and drug deaths. It's taken us probably almost 5 years to get to where we are now, since we had the initial discussion about trying to tackle this issue and setting up the Drugs Commission. Had it not been for the pandemic, I don't think it would have taken us 5 years to get to this point. And this point, I think, is that we are in the starting blocks and ready to continue with further improvements in the service that we provide to drug users and their families. And I'm glad to have the report here today, because we need action and we need it now. And would anyone like to speak to this? The report is by the Chief Officer, but is it who's going to speak to it?
Diane's going to introduce the report, Ken, and happy to collectively take any questions.
And I'm going to get a glass of water, but I'll still be listening. It's a small flat.
Okay, thank you. Yeah, we're happy to bring the report to the IJB, and just to say that this report will also go to the Dundee Partnership and also to the Policy and Resources Committee on Monday evening. So it will be presented at a number of forums in a very short period of time. The report is directly in response to the follow-up report from the Dundee Drugs Commission and includes actions in regards to the recommendations that they made. The Drugs Commission were keen to emphasise that they also felt that the original recommendations from the original report still stood and should therefore continue to be part of our onward planning. While the report highlighted some of the positive moves that have been made, they did feel that even despite the pandemic, that things perhaps hadn't moved as quickly as they would like to. Despite that, there are a range of actions which are progressing at this particular point in time and will continue to progress to support a number of the recommendations. Within the report, you have a number of appendices. First one being the statement of intent, or at least one of the ones being a statement of intent in terms of the commitment from our leaders across the city and involved in the Dundee Partnership to continue to progress and recognise some of the key points which we feel we need to move quite quickly. Those include things to do with where we deliver our services from, including a recognition that Constitution House really shouldn't be our central point of delivery anymore. We should move to much more co-located and working together across a number of partnership areas. It talks about needing to consider a year of kindness and hope and compassion in terms of how we work and support people who use substances, and much more focus on prevention, but doing that hand in hand with people with lived experience. We also include an action plan which is started to set out both the actions from the previous reports and this current report and some of the work that needs to be done. And we've done our best to speak to those who are involved in services to ensure that we get that as accurately as possible, but recognise it still contains quite a number of actions. Our next step is to relook at the refreshing of the Dundee strategy, which effectively came to an end this year. So we needed to relook at that anyway, but we feel that is important. We recognise that while this is a report in regards to the Dundee Drugs Commission, actually Dundee also is experiencing, and we've seen an increase in the number of people presenting with alcohol issues and concerns following from the pandemic. So we need to get back to looking at the whole of our substance use services and how we actually support people in the best way that we can. So the report is there for you. It includes a number of the actions that we're carrying out just now. And myself and Catherine Sharp, along with Vicky, would be happy to answer any questions. And I need to just thank Catherine and her team for pulling this introduction together.
Yeah, thanks for that. Yeah, among the achievements that we have in place that have happened over the last few years, I think one of the key ones, which is mentioned in the report, is the development and evaluation of the multi-agency rapid response to non-fatal overdose. And it says in the report that that was recognised as sector leading in COSLA, but I think it actually won the award in its category, which was heartening. And I didn't realise how many cases had actually been discussed at these meetings, which I think are 5 days a week, but I think we're going to maybe Saturday as well. It's around about 550 non-fatal overdoses that have been discussed and support offered as a result of these discussions. Am I correct in that?
Yes, they're a quite significant number. Obviously, the number will continue to go up, Ken, and it's just a snapshot at the time we write reports. But yeah, significant numbers of people going through. If I can maybe just say something around that, not everybody that goes through that pathway will be looking to go into treatment. And quite often what we're doing is actually providing people with kind of ongoing support. So that could be anything from a food parcel right through to help with housing, you know, finances, etc., or relationships. So it's not everybody that goes through that is actually either requiring or looking to go to treatment, but it does allow us to fast track people where we can.
Yeah, it's very, very useful. Raymond?
I mean, I welcome the report, but I mean, I think, Jan, you know what I'm going to say, correct me, but I mean, we're in discussions with this service and the staff within this service, and to me, the staff are in crisis. We are struggling to staff the area. The staff have reached out to management with their concerns, which we are discussing and we are trying to take forward. I think the board has to recognise that the staff are on their knees, right? They're overwhelmed, right? They're understaffed. And that's no pointing fingers. I'm just saying that's just the reality. You know what I mean? We've got something like, I think the other week we had something like 10 to 12 staff off. We've got currently there's maybe about 8 or 9 staff off. That's just through sick, and then we've got other areas of why they're off as well. You know what I mean? We need to get in and support the staff, or else I could see this all the work that's getting done in relation to this could just crumble and fall. And I think the board needs to be understanding of that criticality of that service. Thanks, Chair.
Yeah, I think you're right, Raymond, because if the staff are under stress and a lot of people are sick, then we can't provide the service. And we have a paper further on in the meeting about the workforce strategy, and we can maybe discuss that in more length. But yeah, the contribution of the staff is key, and without staff, we are nothing. Siobhan Cole is next. Or did you want to come back in?
Do you want me to come back to that? So, yes, we've had an ongoing. Now, I have to say the service is probably no different than many other services, where recruitment is quite crucial at this particular point in time, both recruitment and retention. So we know that that's a common issue. I think the added pressure in the service is the level of scrutiny which goes on, which adds another level of pressure in the service. And we have had quite a lot of funding going into the service, which has also meant that we've had quite a lot of movement within the service. So we've had staff that have moved into promoted posts, and then we've struggled to backfill at the back of it. But Raymond's right to raise it. It is a service which we know that we've struggled to maintain an optimum and an increase. In fact, actually, it's the increase in staffing within that area, and staff are tired. They're tired. So we continue to look at it in terms of things like waiting time. It's in its best place for a while, but we need to continue to look to see what we can do to support because of that extra pressure that comes with that level of scrutiny. Yeah,
I think that, you know, the Dundee partnership did the right thing by setting up the Drugs Commission, but there's no doubt that the increased scrutiny as a result of that must have put so much pressure upon staff. As I said at the outset, I think we're now in the starting blocks, and hopefully some of that pressure will reduce. Now, next up is Councillor Toland, Siobhan Toland, for her maiden speech at the IJB.
Thanks, Ken. I've already raised this, but I'm going to raise it again. The Drug Commission report talked very frankly about the relationship between the first sector and the third sector, or the primary sector and the third sector. There's a bit in that report that maybe kind of slightly addresses it, but I'm just wondering really, what is the strategy for rebuilding that equitable relationship that the DCC continues to say we need in order to kind of push this forward. Just as a maybe slight comment, I would like to kind of maybe state on the record that I think that maybe this report could be a little bit stronger in kind of trying to develop a more active relationship with that. I'm going to draw attention to the fact that, you know, that the Drugs Commission did say that the self-review that was done offered a more perhaps positive light in terms of the relationship, but their review and their interviews had suggested something slightly different. So how do we manage that if we're kind of sitting thinking it's okay because the third sector's telling us, yeah, it's fine, but actually they're telling independent people that actually the relationship's not as equitable as perhaps it should be in order to kind of push this forward?
Diane, would you like to come in?
Happy to take that. Catherine may want to come in, but I'm happy to start. So I think this can be viewed on a number of different levels. I think one of the things that our third sector colleagues were talking about was funding and the temporary nature of funding, and unfortunately that comes into us quite often in that way. We do, however, have with our main providers, we've had block funding for a number of years, which we don't go into review every year in terms of recommissioning that work. But certainly that was one of the things that the third sector are concerned about, and that is not unusual for third sectors to be concerned about that. I think the reality is actually even in statutory services, we're now dealing with a lot of short-term funding and having to make exit plans and think about where we go with that. So that's one of the things that we're looking at, and certainly Catherine's team in terms of our contracting are having conversations with the services to make sure that we're comfortable with where we are. So that's the first thing in terms of the finances, and that's a little bit out of our control, but we continue to look to work together, and we're actually seeing more joint bids going in, which are in both the statutory end of our services partnering with our third sector colleagues in order to deliver services together. So aspects of that. I think the second part, and we do see and do feel that relationships can break down between the third sector and the statutory services when services become tight. And people get concerned about then who is carrying the risk in regards to people that they are working with, and looking for immediate responses that perhaps the statutory service is not able to provide when we hit a crisis in our own part. So we do see that deterioration happening at that point in time. What we need to do is work out how we work together better, and that how we are all seen as being part of the same service in a way that actually means that that risk is shared across the piece and actually managed in a way that people are comfortable and confident about. And I think that's the area that we need to think about how we work better together. So lots of work going on around how the third sector participate and are equal partners at tables. So for example, the medication assisted treatment has our third sector there. They're leading on different bits of work for us now. For example, residential rehabilitation pathway. They're actually going to lead on that work rather than that sitting within the statutory service, and it's that kind of work that we need to do in order to start to develop that shared sense of responsibility and purpose.
Thanks, Diane. Ken, can I ask a follow-up?
Yes, of course.
How will we assess that relationship as we move on, given the importance of that?
So I think one of the things that we need to do is look to see how people feel that they're part of a team, and things like where we actually work from will go some way towards that. It's not the whole way. You can't just put people in a building and expect that to be the answer. So it is about that approach that we're going to take in terms of how we start to plan and actually consider things together and collectively in terms of the work that we are doing. I think we have a wee bit to go. I think we have a wee bit to go in terms of what we're doing. We did have some sessions with our third sector colleagues after the publication of the report where we really asked people to be much more honest with us if they've got issues. Some of the things I'm reflecting back came from those discussions. And so we need to build on that. I think, we need to keep evaluating where we are, and that'll tell us. but we need people to also be honest and raise issues as they come up, as soon as they come up, and not sit with them, so that we've got a chance to address that as we go forward. So a bit of responsibility for everybody.
Okay. And maybe a bit of independent evaluation as well would be useful.
Certainly the ADP will continue to seek to find ways of actually demonstrating that progress is being made.
Thank you.
I think the point about the short-term nature of many contracts in the third sector is an important one, because this work is too important for a succession of 1, 2 or 3 year contracts. And I know that's like, because I was on a succession of 2 and 3 year contracts for many years after I came to Dundee. And as I said, this work's too important. And what happens is, you know, people who are on, say, a 3 year contract, they get to the second year, they maybe don't find out until 2 years and 9 months whether they're going to get their contract renewed. So they start looking for other jobs. So I think that's a really important point. And, you know, shows also that we value the third sector and its role. Dorothy, Councillor McHugh, you're up next.
Thank you. I attended a briefing, as others did earlier on this week, on this topic, and I found it very interesting, enlightening. It's a complex and hugely challenging area, and something I'm just learning about. It's so challenging. It would seem that you're proposing a strategic framework, a delivery plan, a partnership workforce plan, and an investment and commissioning plan. And considering all of that, I'm wondering whether your timescales might be a little optimistic.
Fair point.
Yeah, I'll start, but Catherine, I'm sure will want to come in around some of the kind of more strategic aspects of it. Quite a lot of what's in the action plan, Councillor McHugh, is work that's ongoing now. So it's not starting from a standstill position. It's work that's ongoing now, and it's stuff that we have in the planning in terms of the work. So a number of the timescales which have been put around things have been done from a position of knowing the position that we're in at this moment in time, and what we think we need to do going forward. So a number of the ones that are there are linked to actual kind of work. So that gives us a little bit more confidence, but, you know, all being well and not another wave of the pandemic and that kind of thing. But, you know, so we have a level of confidence around that. Other areas, we have had to make some judgments in terms of our timescales based on what other people feel, but also we have some external drivers going forward. So things, for example, like the medication assisted treatment standards are to be implemented by March 2023 from a Scottish Government point of view. So we've based a lot of our thinking around either is it happening now, what are the drivers and the timescales that are set against those, and then what is it that we think we need to do in order to demonstrate the work going forward. But Catherine, I don't know if you want to talk a little bit about some of the other aspects in terms of the different programmes.
Yeah, that's fine, Diane. And as Diane said, I think the timescales are set out on the basis that we do have a lot to start with in terms of the previous strategy that's been in place, and obviously the information that's contained in the report that you're looking at today as well. I think in terms of that timescale, we are very mindful of some particular things though we need to take the time to do properly. So around developing actions in response to alcohol-related harm, which has been less of a focus in terms obviously wasn't covered within the scope of the Drugs Commission. So we know that that's an area that we need to look at, and it's not to say there's not things happening there, but it needs that bit more attention to bring forward some of the both in terms of our 5-year vision around that, but also in our first year's delivery plan and the specifics that we'll be looking at. The other aspects are clearly around that co-production side of things, and particularly with people with lived experience, with our workforce, communities more broadly, to make sure that what we are bringing forward and the way in which we present that as well. So one of the key aspects of the Drug Commission's recommendations was about improved communication, and as you've already said, Councillor McHugh, this is a very complex area of work, so how we present this information publicly that helps people to understand where we're going, how we intend to get there, and gives us a good framework to be able to be transparent in terms of our reporting on progress is really important to us. and we think that's something that we need to work on. And as Councillor Toland was just raising as well, particularly around the third sector and working through and understanding better some of that areas around the third sector, I absolutely take on board your comment that we're a bit lighter in actions around that. But I think some of that is about exactly what Diane was saying, that need to do a bit of stock taking and making sure we're co-producing those actions, and it's not about us imposing those, but working with Christina Cooper and colleagues at DVVA and the wider third sector to do some of that. So there are very specific things we know we need to focus on in the next wee while in that period up to November, and it's also highlighted and quite rightly so in the report that we'll need to take time to work with others around our integrated impact assessment and particular connivance to the impact that the plans will have on people with protected characteristics, and also thinking about risk to delivery. So we're very clear about, what those might be, where we might need support, both from the IJB but more broadly to make sure that we can deliver on the plan in practice as well. So that's kind of how we'll be spending some of the time. I don't suggest that that isn't tight and it won't be a challenge, but I think it's a challenge that we can rise to and that we're prepared for as well, in terms of key people involved in the planning aspects already having started some of this work.
Yeah, specific timescale that was laid down by the Commission was for the closure of Constitution House, and I think the wording is "and certainly within a year." That's quite challenging. What work is ongoing to identify suitable premises? I don't know what the plural of premises is, but I mean plural. Yeah.
Happy to come in and answer that, Ken. So we are working with Dundee City Council to look to see whether or not their consultancies can help us do this piece of work. We want to do it in a very planned way. So we want to have discussions with our third sector colleagues, because we recognise that in developing this, we would be looking to see where we could be co-located and actually start to deliver services collectively. And we want to involve service users and families to help us think through about what that might look like. It would be fair to say there's not a stock of premises out there just waiting on us coming. So we will have to look quite hard and collectively to see where we would actually deliver that service from, that's going to meet both the clinical aspects, but also the more, not quite social, but the more kind of rehabilitation approaches that we would want to take with any kind of premise. We would like to see more than one, but I think the scoping exercise will help us think that through.
You say well, future tense. Is that not started yet then?
Just in the process of getting that arranged.
Okay. Actually, it hasn't even been approved by the Dundee Partnership yet, but yeah, fair enough. Next up is Jim McFarlane.
Yeah, thanks, Ken. I mean, I'm not going to repeat some of the stuff, obviously, that Raymond raised around the staffing issues are really important, though, about recruitment and retention, and they're not new issues. And it's the same with the discussion just had there about Constitution House. There's been talk for probably at least 10 years, if not more, about that building and how unsuitable it was, and trying to find alternatives and things like that. And I think it's really important about the stuff for staff is really important here. It's all very well us talking about the intense scrutiny that they're under and stuff like that, but that's not new. We've known about that before even the Drug Commission getting involved and things like that. And I see that there's stuff now, quite rightly, in the media around addressing some of the issue about stigma for service users and stuff like that. I think I've mentioned, others have said in the past, there's a stigma now for staff who've worked in that service as well, and they need that support while still trying to manage the day-to-day workloads that they have. So there is an issue about trying to convince the existing staff we have there, and then the staff that you want to recruit there, that this time we mean it, if you know what I mean. And I'm not saying people didn't mean it in the past, but they went through similar type things in the past, saying, yeah, things will change. And reality is, so far we haven't got that right. And all I'm saying is, look, certainly from a trade union point of view, we certainly want to work with you to try and address all that sort of stuff, because without it, we'll just keep going round in circles.
Thank you, Jim. Siobhan, your hand's up again. Your virtual hand.
It is, thank you. Just kind of drawing on some of the issues that's been raised. I mean, being relatively new to this, how often do we review this? How do we review the progress as the IJB? I mean, does this come every month? So take Constitution House, we've got a year basically. And I do feel that I get quite nervous thinking, how's that going to happen within a year? But we kind of need to do it within a year. You know, we need to, because it's urgent and people are in need. And also we were kind of told we need to as well. So how do we assess that progress as the IJB? Does this come back every month to us and we can assess how that's going and set markers?
I could go on the action points, I suppose, couldn't it? Which are covered every meeting.
Well, that's what I'm asking, Ken.
Yeah,
You know, I don't know what the format is every single meeting, so.
Happy to come back, Ken.
Sorry.
I'm happy to come back with some suggestions, Ken. So I think there's a couple of things in here. So obviously the Alcohol and Drug Partnership is the body that we would take those reports to, and we will be reporting at each meeting on progress around a number of these issues, both in regards to the action plan, but also just from a health and social care partnership. I take a paper to that meeting, practically every meeting, in terms of both things like waiting times and performance measures, etc. We also include the risk aspects within our clinical care and professional governance reports, which go to the Performance and Audit Committee, Councillor Toland. So there's always a notification, now not perhaps in the detail that this report has, because that looks at risk, clinical and care risks, as well as updates in regards to that report, and it also goes to the Care Governance Committee and NHST side. What I would be happy to do though, and I think we would want to have an agreement around whether our report goes to Performance and Audit Committee or it comes to the IJB, but we would be happy to bringing regular progress reports to both or either. Might not be every meeting, but certainly we would agree a pattern of reporting.
Yeah, I think that's a good
Thanks,
idea. Donald McPherson.
Yeah, thanks, Ken. I mean, I've been listening quietly to the discussion and agree with points that have been raised, particularly the one that Councillor Toland made about this relationship with the third sector. Yeah, I think that's fundamental to this. I was just going to make a suggestion on her other point that, you know, in that reporting that comes back, sometimes it can be a little bit difficult to see the wood for the trees. So I would certainly appreciate some sort of a RAG rating assessment, you know, on key points like this getting out of Constitution House, so that over the next 12 months we can see, are we on target, are we behind target, you know, or is there no way that we're going to make this target, which is red, and we then as a board can ask for action. So I'd be more interested in clarity than volume, if I can put it that way, in whatever comes to us on a regular basis. But thank you.
It's a good point. Actually, it's today that the Dundee Partnership are considering the way forward and a replacement strategic framework and delivery plan. I wonder, then at the next point, 2.6, I'll be coming back to us. I wonder, do you know what the timescale for that will be after it's agreed by the Dundee Partnership?
So the timescales that are set out, Ken, are that we would have a public consultation draft at the end of the summer with a view to the Dundee Partnership receiving a final draft no later than the end of November for approval. So it would come back to the IJB at that stage. The plan part of it would come back to the IJB at that stage. That doesn't preclude other aspects around our work coming before that, obviously.
I'm glad that so many questions have been asked, because, as I said at the outset, it's such an important issue. This paper is for noting. So, and also at 2.6 to instruct the Chief Officer to submit the replacement strategic framework and delivery plan to us following approval by the Dundee Partnership. So I look forward to seeing that, and we need to continue to make improvements where possible in the interim. I'm aware that the drug death stats, I think, are out in August. So let's hope and pray that we see a further reduction, although of course our aim has to be for 0 drug deaths in Dundee. I think I should probably also mention alcohol issues, which have been briefly mentioned, although drugs tends to get all the media coverage. as people will probably know, more people die of alcohol misuse than die of illegal drugs. So it's important we don't lose sight of that fact, and don't lose sight of the fact that we need to continue to improve services for those with alcohol problems too. And it can't be forgotten about. So thanks everyone for your contributions on that. I will be having a break. I think that's in the standing orders that the chair gets to decide if and when there shall be a break. We've been going for an hour and we are on item 7, I think, aren't we? I wonder.
Thanks,
Yep, I'm listening to you, Willie.
Yeah, we're just about to go on to item 9, which is trauma-informed practice and leadership. We've covered item 8, reducing harm associated with drug use, and that's been noted. So yeah, we would be going on to item 9, their trauma-informed practice, but I'll take your guidance, Chair.
Yeah, I think we'll take this and we'll have a break afterwards then for 10 minutes, if that's all right with everyone.
Sorry, Chair, if I could just so you're aware, my Angus IJB audit committee at 11:30.
Oh, okay.
Did make Dave aware, so if it's at all possible, it might be helpful to take that report and my report now, because otherwise I'll be running into the other meeting.
Yeah, absolutely. I think that's a good idea. Totally agree. Is that item 11?
It is indeed, JS.
Yeah. Can we go to item 11 then? Dundee Integration Joint Board Annual Internal Audit Report.
Okay, thank you. So I don't know if you want to start, Dave.
Yeah, I'll just do a kind of quick introduction here to this paper, and I'll pass on to Tony. So just for kind of IJB members and particularly new members information, this report is a requirement. We kind of, as an IJB, we're required to appoint an internal auditor. And Tony is the Chief Internal Auditor. Their audit services are provided as a collaboration between the local authorities, auditors, and Tony in terms of the sort of NHS side of things. But Tony is the kind of Chief Internal Auditor. It is the internal auditor's responsibility to provide an annual assurance statement back to the board. Based on the kind of work that they've done over the course of the year, but also kind of quite an intensive piece of work at the year end to kind of just do an assessment of our systems of governance and control, and also kind of risk, and kind of provide an assessment as to whether they feel that our systems are adequate and appropriate. So the report you've got attached to the agenda kind of covers Tony and his team's kind of opinion on that. I'll pass over to Tony, who'll go into a bit more detail on that one for you.
Thanks for that.
Okay, so for those of you lucky enough to be on the audit committee, you'll have seen this before. And normally this report would go to the audit committee. It forms part of their consideration and deliberations in terms of recommending the accounts to yourselves, but and indeed passing on the accounts to the external auditors. But because of the timing this year, because of the elections, it can't go through the audit committee. So you're having the joy of it today. And that can be helpful, I think, because there's some important messages there. It's not just a summation, as some annual internal audit reports are, of the work we've done during the year. It's a holistic overview of the entirety of your internal control systems. So it's an important document. I certainly won't read it out. You'll be pleased to know, apart from one bit, which formally I have to read the following section, which is that we've delivered our audit plan, that in our professional opinion, based on the work we've done, reliance can be placed on the IJB governance arrangements and systems of control for 21-22. That in terms of the draft governance statement, we have no concerns around consistency, format, or disclosure. So that's the formality. What I would do with your permission is just touch on a couple of issues which I think are important in that, because in looking back, we also look forward. So the whole point of this time of year, and particularly in terms of when we present this to an audit committee, we're looking back at the year that's just gone and saying what we need to really focus on moving forward. And not surprisingly, given the circumstances, a lot of that has to do with strategy. So we've gone into quite a bit of detail in the report about the strategic response to what is a very difficult short and long-term environment. And in our view, there will be difficult decisions to be made. And probably one of the key points that we made in the report is that whilst the IJB will need to be cognizant of SG ambitions, of public expectations, its priority must be the production of a realistic, achievable strategy which addresses the needs of the local population post-COVID within the parameters of available resources, most particularly financial, digital and workforce. And this will almost inevitably involve extremely difficult decisions which may not fully align with public or SG expectations. And you've already talked about workforce, you've got the workforce plan later, but there is no doubt in our view that if you look at the pressures on the health sector, on the council sector, on the third sector, on the private sector, that these are going to be, well, not amongst, they will be your biggest risks. There'll be associated financial risks, which we touch upon, but workforce is a massive issue. And what you're going to have to do is decide what you can deliver within the parameters of the workforce you'll have available, accepting that there are things you could do to increase that, but also accepting you're in an environment where everyone else is doing the same things to attract a limited pool of people. That's one of the biggest messages. Within that, we've touched on finance, and there's a general point around the fact that money has been flowing through the system. For the last couple of years, money has not been the priority in the way that it has been previously, perhaps. And money, when I say money is a priority, it's not about the money. It's about the fact that limited money means you have to make choices about where you devote your resources. And to a certain extent, that culture, that discipline has dissipated across health and social care because we had, the biggest priority was just dealing with the pandemic. And at the moment, and we see that from your financial plan, we don't need savings next year, but we definitely will in future. And in a sense, what we need to do is understand that all we've got is time, because those financial pressures will come. Those workforce pressures are here already. And the reason we mentioned digital is it's not within your purview, but you rely on your partners to provide you with the digital solutions you need to be able to transform services. So those are the key messages. A couple of other things I'll touch on about performance and risk management. There's a lot of stuff about risk management which you expect from an auditor. And even in terms of the discussion on drugs you just had, later discussions you'll have, there's something around making sure that we keep working on linking performance, strategy and risk. And there's been a lot of good work done. So we're not saying that, but it's a journey and we're not fully there yet. And as auditors, we're always going to mention that until we reach the kind of nirvana of everything being fully integrated. So that's something to think about. And I think it's not just a technical issue, it saves time. So when you talked earlier about the assurance on the drugs action plan, there's something there about saying, well, actually that drugs action plan will be a key action, key control in terms of your response to your strategic risk, which is currently very high. So actually, if you can integrate those things and it comes through as part of that routine assurance reporting on that risk, you're not duplicating, you're not adding more work. It's actually the way you would do your business in a way that allows you to judge how you're managing your biggest risks. So these are all the things that are in there. I think the integration scheme we mentioned, and maybe that didn't, that process didn't provide the answers to all the questions that we might have hoped, and maybe that wasn't a realistic expectation. But apart from that, really, I hope the report's self-explanatory. I hope it provides meaning and value to you. And finally, I just want to thank my team and indeed the Dundee City Council team for their contribution to the plan, and also Dave and Vicky and Diane and Catherine, because we do have very good working relationships with officers, and that helps us, I think, to provide a better service, because we do get cooperation and we do have the opportunity not just to hit people with audit reports, but to discuss issues and hopefully come up with more fruitful solutions. So that's all I'd like to say, and thank you for taking me early. And if there's any questions or comments that people may have, then I'll be more than happy to take them. Oh, you're muted, Ken.
Oh, you're on mute, Ken.
All I was saying was any questions, but no hands have lit up, so I'm assuming no. Thanks very much, Tony. And yeah, the point you keep making about staffing is absolutely crucial. You made that point. Now, where was it? Was it the briefing on the Drugs Commission report the other day? You made that point as well. So yeah, and then of course, as you said, we have the workforce paper as well. That's our key challenge. And thanks for hammering that point home. And I hope they're kind to you at the Angus IJB. At least you don't have to travel from Dundee to Arbroath or whatever they're having it.
Well, I've actually done Forth Valley at 9 o'clock. Yes, I was on the old days, I mean, that's one thing with remote working. I don't think I could have done Stirling, Dundee and Angus without breaking all sorts of traffic regulations. So at least it's easy now, and I get time for a cup of coffee in between. So thank you very much for taking me early.
Right, thanks very much, Tony. That can be agree the recommendations at 2.1 and 2.2, unless there's any hands up to say otherwise. No. So it is now 11:11. Can we come back at 11:21, please? And you can do whatever you like with the 10 minutes. Suggest you have a refreshment, and I'll see you at 21 minutes past. Thank you. And we can resume with item 9.
It was item 9 here, yeah, the Trauma Informed Practice and Leadership Update. This report's for noting.
Yep, and I noticed we have a briefing session by the end of the summer. Who would like to speak to this?
I'm going to start this one off, Councillor Lynn, and I think Diane might want to come in as obviously our trauma champion as well. I'll keep this fairly brief because I'm mindful of the time, the papers that are left, because it is an update report. I think we brought a report to the IJB last in December around this area of work, and there was a lot of interest from members, which was really helpful. So this is really setting out some key areas of progress. I think it obviously links really well to the conversation we've just had about responding to the harm caused by drugs in the city, not just in terms of people's experiences of trauma and how that interacts with their drug and alcohol use, but also in terms of some of the points that were raised around the workforce and the impact for them too. So hopefully people can see the links across. Just to like a few things, been a huge amount of activity over the last 6 months led by our trauma steering group, which has a focus on council and health and social care, but also extends to third sector, and we're discussing with the police representation as well around about that and strengthening that. And I have to say there's really a big commitment and a lot of enthusiasm in the city and positivity around this agenda and moving it forward. I think it aligns really well with lots of people's professional values and training already, and it's exciting opportunities to change the way that we deliver services and support our workforce as well. So we've had the launch of our Becoming Trauma Informed materials, which really have tried to set out a whole range of ways in which people can get involved in this work. That might be about leadership, it might be about staff support, some of it's about test the change of different delivery within services, but encouraging people with ideas to come forward and to take some responsibility for progressing that themselves within their service, and to be supported to do that with some resources and training and development that we can offer. Another key development has been the partnership that we've formed with the Women's Rape and Sexual Abuse Centre, using some of the national monies that Dundee City Council were allocated, and that's really been focused on trying to enhance our delivery capacity around our implementation plan for trauma. So an area where we have a lot of ambition, but we need to have some capacity to support us to move that forward. And the members of the steering group are very much involved, but we do need somebody to be doing that work day to day and to be moving some of the areas forward, particularly around training and workforce development and organisational development. So that's been really positive to have that partnership with the third sector to be able to do that. Continuing to be really active in national forums. In fact, we were quite regularly overwhelmed by the number of requests that we get to go and present in national forums about the work that Dundee is doing. We've had an opportunity to do that with the Minister, but also a lot of other local partnership areas asking to do that. So we're trying to think about how we might share materials and learning with people, whilst also just protecting our own capacity to deliver locally, but obviously want to share that best practice wherever we can do. And one of the most recent developments has been around the launch of our workforce lived experience work. So there's been a lot of really careful thinking that has gone in to how we support members of our workforce with lived experience who perhaps want to make a contribution to work that's mostly about, at this stage, about looking at our organisational culture and supports to our workforce, to be able to come forward and to participate in that work in a really safe and supported way. So colleagues have just been launching the materials around about that, and that's included discussions with staff side colleagues and a whole range of other people about making sure that's safe for members of our workforce that want to do that. So we're excited to see where that goes. And they'll very much be guiding the agenda about where they want to make that contribution and the areas where they'd like to focus in terms of supporting our trauma-informed implementation work. Looking forward, absolutely, the local briefing session. We have a provisional date of the 15th of August now, so there'll be information coming out to both IJB and council elected members, and also we'll be looking to see who else we might want to open that up to as part of the kind of induction programmes that are going on for both the IJB and council. And that will be supported by the improvement service, but also local colleagues. And I know it's been a long time coming, so thank you for your patience around that. But hopefully that will help to consolidate some of what's in the paper and people's understanding of the work we're doing. We're also looking to think about where we spend our 50,000 trauma-informed implementation money that we have allocated to the council for this year. And thinking about, we've got some key developments going on at the moment, so just thinking, reflecting on that and where we might be best to invest to add some value to the things that we have ongoing just now. Also giving some consideration to how we expand our trauma champion model. So Diane, Francis Gregg and Elaine Verline from the council are our local training trauma champions, but we're also, there's enthusiasm for other people to get involved in that and thinking about how we can involve more leaders across the partnership in that aspect of work, and there might be opportunities for a range of different people from a range of different perspectives. I know Police Scotland are also pushing to be included in that arrangement at a national level. That's some of the highlights. Unless there's anything Diane wants to add to that, I'm sure we'd both be happy to take any questions.
Anything to add, Diane?
No, I'm happy just to, I think Catherine's covered everything I would have wanted to say, Ken, so happy just to go to questions.
Yeah, and I see Sarah Dickey's hand is up. Hi, Sarah.
Hi there, thank you, Chair, and thank you very much, Catherine, for your paper. It really wasn't a question, it was more a response and comment of support for this approach that's been taken. I think any response that sees us responding in a way that prevents further harm can only be incredibly helpful for the people that we care for in our communities. And of particular interest to me is some of the support mechanisms that go significant ways to addressing inequalities in health and improving life chances for those in our communities that may be most vulnerable. So really just to give my support to that and encouraged around the spread of the training opportunities. As we know, nursing is one of the largest workforces working across the health and social care partnerships provision of services. So I'd be keen to see that spread further. But thank you very much. Really supportive of the paper.
Yeah, me too. I think it's fantastic that the work that we've done in this area has been recognised at a national level, because, my God, people of Dundee have certainly had more than their fair share of trauma, and it's good that we're working this into our practice. I know we're having, I'll have more questions when we have the briefing. Just at 4.2.4, it talks about mapping of training and delivery, and I'm particularly pleased that there's 141 managers have attended to date. Well, with that training, just from a point of self-interest here, maybe for the other elected members, is that training going to be available to elected members, maybe at level 1 or 2? I can take that request away for the steering group to look at. The level 1 training is actually quite straightforward, a kind of online resource as well, so there'll be opportunities to make that available, I'm sure, Councillor Lynn, and I can take that back into the steering group alongside Diane in terms of thinking about that. I think in the first instance we focused on the employed kind of workforce, but absolutely I think maybe there is a bit of a gap there in terms of reflecting on people sitting in different positions around our system and our governance aspect around what might be useful to you too. Yeah, because we certainly interface with the general public on a regular basis, just as staff do. Councillor Toland.
Thank you. Just kind of picking up on something that Ken said. I mean, I did kind of approached someone about, I can't remember her name actually, about the trauma-informed training, and they said that they were going to make a date for councillors and elected members to kind of get that. I mean, I think it's a great initiative. I think it's a long time in coming, and I think it's something we could be really proud of, genuinely, because I think it's vitally important. I do have a question. It's not just a kind of gushing response to how great it is. You said, and Ken mentioned this as well, that you've offered training April and May 2022 to 141 managers that have attended to date, which is actually great going. Maybe I'm being slightly stupid here, but I'm just trying to get a sense of how you're going to work that. Are you extending that beyond managers, or are the managers expected to kind of extend that in a ripple effect? Are you kind of hoping that all staff within the kind of partnership will be trained eventually?
Yeah, so we have a comprehensive mapping across the council and the health and social care workforces, and the NHST side have their own mapping around about that to allocate posts against the level of training that's required. And that's a really significant undertaking. You can imagine the number of staff, given the background in Dundee, who require at least some level of training. And partly why we've invested in that partnership with ASAC to help us to move forward some of the delivery. Some of that is quite specialist, so would be much smaller numbers, but equally we also then need training providers that are quite specialist, and there's a lot of competition because everybody across Scotland had some extra money to look at this. So we're trying to look at that and work in partnership with our learning OD colleagues across Tayside as well to try and do the best we can to secure resources here. The managers training was very much about making sure that when staff were wanting to participate and also taking forward some of the learning aspects that their managers had a grounding in this as well, because we recognise that it can be really difficult for staff to go on training, to go back to their workplace and want to do something differently or try something if their manager doesn't have the understanding the context around that too. So absolutely at all levels there's been leadership training as well for our chief officers group and for others. So yeah, how do you eat an elephant one bite at a time stuff as far as this is going, and trying to be clear about what the overall picture is and move it forward in manageable stages and be realistic about how we can do that and involve people.
That's an interesting comment about how do you eat an elephant. I've never heard that one before. So Siobhan, do you want to come back in there?
Just to think that I think that clarifies it for me actually as well, and I think we'd all be keen to get some training in that.
Absolutely. So keep up the good work. I look forward to the briefing session at the end of the summer. So, see, at this point, something which occurred to me during the break was, did I ask the board to agree the minutes of the previous meeting? I'm not sure I did.
They were agreed, I believe, Chair. Yeah.
Well, thanks for that, Willie. I knew you would have noticed. I just wanted to double check. We can move on now to item 10 on the main agenda. It's an agenda note on, Willie.
This is Chair, item 10 then before is the agenda note, revision of Dundee Health and Social Care Integration Scheme, and this is for noting.
Yeah. Any questions on this?
Chair, I was just about to say, in terms of this one, this is just a kind of further update. As you know, we've kind of provided updates on the progress of the revision of the scheme throughout the year. This is the revisions now kind of coming to a conclusion. Both Council, Dundee City Council and NHS Tayside Board will meet next week to agree or otherwise the kind of changes to the integration scheme. And after that, it'll be then submitted to Scottish Government for approval, and then as an integration joint board, we'll then kind of present this back, hopefully in August, if the timing's right, to kind of share what that the kind of the new scheme for adoption by the two partner bodies on here. Probably just kind of main thing to note, following the consultation exercise, so members, or some members who are in attendance would be aware of that we did kind of highlight a couple of areas in particular that were significant changes that would potentially impact on the IJB, that being the introduction of further change to the financial risk sharing arrangement, whereby where if the IJB is overspent come the end of the financial year, and following a number of steps, including kind of a recovery plan, use of reserves, any residual overspend in the past was met by the partner bodies on a proportionate basis. There is now an additional kind of element within the risk sharing to say that that overspend may then have to be repaid by the IJB back to the partner bodies in future years. So that's the significant change. That has now been included by the partner bodies as one of the provisions in the new scheme. And the other element was around a more limited statement of intent around support, corporate support elements to the IJB. So the IJB relies on the partner bodies to provide a kind of whole range of corporate support, including HR and IT. While we had asked for a bit more specific information to be included in the integration scheme on that, that has not been included in the scheme, goes as was intended by the partner bodies. So we'll see what happens next week in terms of the approval process, but that's the update in terms of where we are just now.
Yeah, thanks for that. And that significant change you mentioned about overspend, that's kind of slightly softened by the use of the word may be required. Councillor McHugh.
Here it comes, the daft lassie question. What is an integration scheme? What is it?
Not a daft question at all. So the integration scheme is it's in effect the agreement between the two partner bodies, i.e. NHS Tayside and Dundee City Council, as to how the arrangements for the IJB will be operated, how the IJB will be run over as part of that arrangement. So it covers all elements, including the appointment of the chief officers, the financial arrangements, the risk management, clinical care professional governance, and there's a kind of whole range of kind of governance aspects that are then kind of set within that scheme. IJBs need to have an integration scheme. It's kind of part of the legislation. So the initial integration scheme was around it needed to be put in place before an IJB was established. And it requires a statutory revision after 5 years. So that's the process just coming to an end now in terms of the revision by the statutory partners on the integration scheme itself. So hopefully, once we get to, hopefully April, maybe August, it may be later than that, depending on the Scottish Government's approval, we'll kind of lay that before the IJB for noting, because it's not up to the IJB to agree that, it's the partner bodies themselves.
Okay, so basically how the whole thing works.
Yes, we'll pick up on some of that at the induction session penciled in for next week.
Thank you.
That induction session, is that for new members?
For any members.
Members. I'll certainly come to that. Yeah. And Martin, how are you today? You're next up.
I'm very well, Ken. Thank you. Just a quick tangent on this. As most people will be aware, the National Care Service bill was raised in Parliament on Monday and was made public yesterday. Has there been any thoughts on how we're going to look at this in the future, in terms of, are we going to have development sessions, because it is going to impact on the integration scheme quite substantial, if not completely rewrite it. So I just wanted to see if we're starting to think about that process now.
Vicky, would you like to come in on this? Is it?
Yeah, thanks, Chair, and apologies, my virtual hand isn't working, so I have to use the live one. Yeah, and thanks, Martin, and I know that you've passed on some other documentation which you'd received directly, which we've shared certainly initially amongst the management team, so thank you for that. I went to a briefing on Monday evening prior to the launch of the information on Tuesday about the National Care Service. And I think you're right to highlight that as quite a considerable issue that we need to consider through the IJB, both in terms of the impact, but also to be able to translate some of the messages that are in the bill and make those available for all of our partners and all of our frontline teams as well. So I think we just need a wee bit more time to digest the information. I know that there's some national communications material being made available, particularly targeted at frontline staff, because there are components of the bill which probably do require a bit more exploration and certainly some extra explanation in terms of how that will affect our integrated teams, because obviously we've spent 7 or 8 years now building integrated health and social care teams, and certainly on the face of it, the bill would be suggesting that there might be slightly separate arrangements for those who've traditionally come from a local authority background and those who've come from an NHS background. So quite a lot to work through. The only issue I would like to highlight at this stage, though, Ken, is that we were given a full assurance by civil servants on Monday evening that in no way do they wish for the new bill to undermine any of the gains that we've already made through integration, because there were some questions about whether this would start to almost separate the provision of NHS services away from social care, because there's a lot of emphasis within the bill around social care and how that will be part of the National Care Service. But they were at pains to express really very, very strongly that if anything, what we've achieved through the integration of health and social care through the IJBs is merely the baseline for moving forward, and that they don't wish to see any of that, if you like, changing or taking a backward step. So I think we should take a week or two, look at the information and consider how best to be able to communicate some of the key messages from that. And I'm sure officers would be open to the suggestion of maybe a development session for the IJB. So we could look into scheduling that probably later on in the summer at this stage.
That'd be good. Anything else that you want to add, Martin?
No, that's everything. Thank you, Chair.
Yeah, I haven't actually read the bill in full yet. Just got it late yesterday afternoon. I think it was you that sent it, Vicky, was it? Or was it straight from the Scottish Government? It doesn't matter anyway. But I've just read the kind of outline of you know, the way forward over the next few years to bring in the National Care Service to fruition. So yeah, development session would be good. And thanks for raising that, Martin. Yeah, this is obviously for an agenda note for noting. So we can now move on. We can skip item 11, we already had that, and it's on to item 12, unaudited annual accounts. And Dave Berry, I imagine, will be speaking to this.
Yeah, thanks for that, Chair. Yes, again, just for members kind of to note, as a statutory body, the IJB is required to develop and present a set of statutory annual accounts. And that includes an annual governance statement, which kind of coupled with kind of Tony's report that he just presented earlier, that kind of provides our own assurance back to the IJB and to various stakeholders that we've got sound and appropriate systems of governance and control that are in place. And so the process is if IJB members are content to approve the draft accounts today, they'll then be submitted to Audit Scotland as our appointed external auditor to carry out the audit process, and that will take place over the coming months with a view to presenting the audited accounts back to the IJB probably around about the October IJB. So that will conclude the audit accounts and our statutory responsibilities around that. In terms of the detail, in terms of what the accounts tell us, the accounts for the year ended 21-22, as you can see, showed that we had made an overall surplus of just over £25 million in the financial year just gone. And that consists of an operational underspend of just under 8 million, about £7.8 million there, plus additional funding received by the Scottish Government near the year end that's been put into earmarked reserves of £17.3 million. So that kind of gets us a surplus of £25 million. And that obviously is quite a significant surplus that's been made. and that is mainly down to kind of COVID and the receipt of additional COVID funding from Scottish Government to kind of ensure that we have sufficient resources to meet our additional expenditure coming through for our response to the pandemic, both in the end of 21-22, but also carrying forward into 22-23. And a feature of a lot of the funding that we have, and particularly the amounts that are sitting in reserves, which now takes a reserves figure up to £39 million. £29 million of that £39 million is actually earmarked for specific initiatives. So in the main, it's from Scottish Government funding that we can only spend that funding on the intended nature of the reason it was kind of given to us in the first place. So that is kind of mainly around primary care improvement, Action 15 mental health, alcohol and drugs through the ADP, but by far the biggest amount now is the COVID reserve. Now we can only spend any of that funding, and particularly the COVID funding, on services that are delegated to us, and that includes unscheduled care under the large hospital set-aside arrangements with NHS. So as we move into this financial year, 22-23, we are in discussion with NHS Tayside and the Scottish Government about the use of that COVID funding. It will takes away any financial risk that we have of residual COVID expenditure within 2022-23, and as I said, within unscheduled care, will also cover some of the additional costs that are covered in there. I must stress that the £39 million reserves that we've got were not any different from any other IJB. We're all in the same position across the country because of the additional Scottish Government funding that's been provided, and particularly the kind of the levels of COVID funding. I think there's something like £500 million worth of kind of COVID reserve money sitting across the IJBs for use into 22-23. We've got another paper on the agenda which will kind of just detail a bit more of the operational kind of underspend. So it kind of ties in with the financial monitoring that has been presented to each of the IJBs throughout the year. So you can we can do a bit more of a comparison between the projections and what the year-end position was. Over the next few months, we will be bringing back kind of proposals to the IJB with kind of regard to investing those reserves, so the reserves that are not ring-fenced, and that will be to kind of support activities within the current financial year and probably next financial year as well, and really to kind of give us more of a kind of strong foundation to move forward into some of those more challenging financial years ahead, which again I've outlined in another paper on the agenda today, because we know there's going to be quite significant financial challenges ahead for us. So if we can invest that money wisely now, that's going to help us as we get to those kind of challenging financial years. So the draft accounts are here, are kind of presented today for approval by the IJB for me to then take these back to the auditors. We would get these, so the accounts will be signed if, assuming that the IJB then can approves them, and we'll get them submitted as soon as we come back to the auditor. So happy to take any questions or comments on them.
Yeah, it's kind of surreal to have 39 million in reserves, Dave, because I remember when I think they were less than 5 million at one point, weren't they? Not so long ago.
It wasn't that long ago, we had 450,000, so you're right, yeah.
Significantly less.
Yes.
Reassuring that we're not going to be asked to hand back any of the COVID money. Oh, well, he's just left us. Oh dear. I'm sure that's just some sort of technical problem, and he'll be back. And I forgot what I was saying. What was I saying?
We're talking about the reserve fund and level of reserves.
Yeah. Because we don't know what lies ahead really with COVID, with a new strain, and also, we may have the effects. Well, we will have the effects of long COVID to deal with, and the additional strain that puts on resources. So yeah, we're in a good position at the moment, that's for sure. Dorothy, Councillor McHugh.
Thank you. Yeah, it's a question on the reserves. Your report 4.1.3 item B says that the reserves have increased due to significant levels of additional funding received at the year end. Now, my question is, was that expected at the year end? Did it arrive late? Or you know, if it arrived late, did that have any impact on planned service delivery, or was it expected at the year end?
Yeah, thanks for the question, Councillor McHugh. Yeah, so the majority of that additional funding that came in, so there was £16 million came in that was announced in February from Scottish Government around additional COVID funding, which was to cover any residual residual commitments that we had within 2021-22 for COVID funding. So we did have reserves carried forward from the previous year into 21-22, and any residual monies that we still needed to claim back from Scottish Government was covered by that additional money, the 16 million that came in February. But the Scottish Government were quite clear that that needed to be then put into reserves as a ring fence to carry forward to support us in 22-23 and beyond. And that also extends to anything within NHS Tayside Board's position relating to unscheduled care, which is part of our delegated arrangements as well. So it wasn't anticipated that we would have that level of funding coming through as we did our financial monitoring throughout the financial year. It was a very late adjustment that came through.
Thank you. I think I understand that. I'm trying to get the head around it. Thanks.
Jenny Alexander's next.
Yeah, thanks, Chair. Sorry, but we're just coming back from leave and just getting told I'm a proxy for today. Haven't really had a chance to read fully the papers, Dave. However, it's on page 15 of your report that I've got just needing a little bit of an explanation about how that you've had an underspend in the learning disability services, the social services, including learning disability, of an underspend of 572k, and the older people care home placements of another underspend of 567k. Were these people not getting any assistance during the pandemic?
I'm sorry, I think you're looking at the financial monitoring report itself. So I'm just trying to find the detail of that on there.
Same report. It's the same.
Oh yeah, sorry, got it.
Sorry,
it's the narrative
page.
Yeah, so with respect to the learning disabilities service, we had put in additional money to support some further development within learning disabilities as part of the budget setting process. So there were a number of accommodation with support developments that had been planned for that we added in significant amounts of money into the budget. And because of the continued impact of COVID, a lot of the building work on those was delayed. So the care pack, so people didn't move in at the time that we anticipated them to move in. So that's why there was a kind of delay on that between us, the planned investment and when the actual investment took place in terms of that. In terms of care home placements themselves, as you know, care homes were significantly impacted on by the pandemic, and throughout the year there was kind of restrictions placed on a number of admissions to homes because of kind of COVID outbreaks. So care homes were given under occupancy payments from the COVID funding, which then supported any under occupancy. But what that meant was our mainstream budget, where we would be making placements all the time, was then impacted on in terms of a reduced placement activity within care homes, because we couldn't place people at that time. And that's obviously had a knock-on effect on other elements of the system, including the delayed discharge position. So it wasn't because we didn't want to place them, it was just it was not safe to place people there. I see Jenny's got her hand up as well.
Yeah.
She might want to add to that.
Yeah.
Yeah, I was just going to add to that in terms of we know that older people don't want to be in care homes and want to be at home, and the pandemic did see people, you know, that became much more real for people and that they didn't want to go into care homes. So actually, in some ways, if we see that budget reducing, that's a planned and strategic change.
Yeah, Chair, can I come back?
Yes, yeah.
Yeah, so I get that, Jenny, but it also is that quite a lot of these people will be the delayed discharge people, especially the learning disability ones. There's bound to have been a knock-on effect, like what Dave was saying earlier in his answer to me, was that there's a lot of delayed discharges.
So I can answer that in relation to care homes, that doesn't tend to be our biggest area at the moment, but what has happened through the pandemic is we've seen a lot of delays that have happened because of short-term closures in care homes. So that's become an issue at times when they've been closed for COVID. As that's opened up again, we're not seeing that. So we tend not to have delays waiting for care home placements. The biggest area of challenge for us at the moment is the availability of social care, to care for people in their own homes.
I just comment about the learning disability side of things. So, so in terms of the learning disability, the various developments, the service users that would access those kind of services wouldn't necessarily be ones that are in hospital. They'd be placed for a number of different reasons. So they could be within a family setting already that's got older carers who are no longer able to cope. So they wouldn't be in a kind of hospital setting, for instance, on that. So it's not, there may be some that would be in a hospital setting, but a significant amount of them will come from a different range of backgrounds. Some of them might also be kind of younger adults transitioning from children and family services, and that's an appropriate, you know, a brand new kind of development with the kind of most modern adaptations to the accommodation is kind of more suitable for them. So in years gone by, the traditional route would probably be either hospital or a care home, but we've now got more investment in individual kind of units with support.
You happy with that, Jenny?
Yes, we are. Yeah, I note it. Yeah, I'm not happy about delayed discharge. That people are in hospitals and not in the right places.
Of course not.
But
No.
I note the answer.
I see no. Well, Jenny's hand's up again, or is it a legacy hand?
If that's mine, that's a legacy.
Okay, thank you. So yes, can we agree the recommendations from 2.1 to 2.4, which conclude by instructing the Chief Finance Officer to submit the unaudited accounts to the IJB's external auditors by the 30th of June. I see no dissent, so that is agreed. Thank you.
Okay, thanks very much, Chair. Takes you on to item 13, I believe, the year-end financial monitoring position, and this report's for noting.
Yep, Dave, would you like to speak to this?
Yes, I'm going to pass this one on to Christine Jones as Partnership Finance Manager to take you through a bit more in detail this one. Thank you.
Thank you. Yeah, just for the benefit of our new members as well, this is a regular report that we bring every meeting through the financial monitoring. This format is brought to each of our meetings, and this particular report is just closing out our 21-22 financial position in the same format that you're used to getting. It does duplicate an awful lot of the information that Dave has just shared, and it's effectively the same set of numbers that's presented as part of the annual accounts. But the annual accounts includes a number of statutory adjustments and additional information that we need to provide to meet legislation. But this particular format is presented in a way that's hopefully a bit more consistent with and comparable to the rest of the reports that we present throughout the year. So that's why it's brought in this format as well, although it does look like, as I was saying, it's almost duplicating the financial information. Dave's probably already covered most of the things that I would have wanted to highlight, so apologies if if I say the same sort of thing already. But as the report does highlight, we had an operational underspend of 7.8 million for last year. This was actually an improvement from the report that we presented in April, I think it was, based on the February position. And a lot of that was due to the additional funding that we received during the latter part of last year, that we were effectively dropping straight into our operational position of additional sort of £3.4 million that was dropped straight into it. Sections 4.3 and 4.4 and the appendices of the report highlight a number of the key variances that we've had across our delegated services. And section 4.5 also presents the same information that Dave's just talked about in terms of our COVID spend, which totals of £7.9 million last year. And all of that was fully covered from the additional Scottish Government funding that we received, and then obviously the surplus has been carried forward as an earmarked reserve into the new financial year, again for use on COVID-related expenditure as part of our either delegated services or our delegated responsibilities through the unscheduled care spend through NHS Tayside. As highlighted in 4.5.8, Scottish Government have confirmed and made it clear that there is no further COVID funding will be available from Scottish Government. So we need to obviously manage the balance that we have as best as possible to continue to cover our additional COVID spend that may be coming through. And just one final point just to highlight as a change from our previous report, 4.3.5 confirms that the Dundee IJB's contribution to Tayside inpatient mental health services last year's overspend was 276,000. This is actually a lower figure than we'd previously suggested from the previous report. I think was in the region of about 500,000 or 600,000, I think we were suggesting. So that's obviously a slightly better position than we were perhaps indicating in the last report. And our conversations are still ongoing between the CFOs, NHS Tayside Finance and the operational positions as well, as to how the financial risk for the inpatient mental health overspend will be managed in the new financial year 22-23 and any future years. So once we've got some clarity on that, we can bring that back to future meetings as well as to what our contribution to that position will be. I think that probably covers everything in terms of the additional points I wanted to highlight in conjunction with the paper, the annual accounts that Dave's just talked about as well. But if there's any particular questions on this, I'm happy to pick them up.
I see no hands unless someone's hands up function isn't working, in which case you could just put your hand up. I think it's only Vicky who's in that position. So I don't see any hands. So this is for noting. Thank you. Can we move on, please?
Yeah, thanks, Chair. Takes you on to item 14, which is the agenda note, the De-Integration Joint Board Budget Update. This is also for noting.
Yeah, sorry, Chair, nothing probably else to add to that agenda. It's pretty self-explanatory.
Yeah.
We've got the provisional figures from NHS Tayside for our budget in March. The figures that have been agreed by NHS Tayside are the same, so no further action we need to do on that.
Yeah. So it's on to the next item, please, Willie.
Yeah, if item being noted, item 15 then is the 5-year financial framework. You're asked to give your recommendations.
Okay.
Okay, I'll take you through this one. So we've kind of had we've kind of prepared a similar report last year in terms of a kind of 5-year, a longer term financial outlook for the IJB's delegated budget. Previously, we just kind of did an annual basis, but we've kind of worked through a number of recommendations with Audit Scotland and have kind of created the sort of 5-year financial framework, which kind of does help us kind of look into as best we can into the future in terms of where we think the IJB's budget may be, and kind of takes into account as many of the things that we think we know about. Very difficult, as you appreciate at the moment, given the the rapid changes in the economic position and the state of public finances as a result of that. But also in terms of things like kind of pay awards and inflation. Again, this morning inflation was noted to go up, nudge up again this morning. So, you know, I think it's one of these. This is one of these papers that as soon as it's written, it's kind of out of date, but it is our kind of best estimate at this moment in time. And you'll see what we've kind of done is we've kind of linked the kind of the Scottish Government spending review with you know, how we think that might then kind of pan through to the IJB's delegated budget. And again, for newer members, in terms of how the IJB is funded, it's funded from the NHST side and Dundee City Council, so they kind of provide the funding to us. And we also have specific funding that comes through Scottish Government, which will flow either through NHST side or Dundee City Council to the IJB. So we've kind of taken a range of assumptions around what that funding level might be. Is it going to be a flat cash? So for a local authority, we've assumed a flat cash settlement over the next few years. We've assumed a small, kind of different levels of uplift from an NHS board perspective, because the announcements around health and social care being relatively protected in terms of the kind of future budget setting. And again, we're trying to use as many of the sort of national kind of information, as much national information and assumptions as we can as we come to that conclusion. Made kind of significantly higher allowances for things like pay awards because of the economic position at the moment. Things like the implementation or further implementation of fair work in social care and the implications of that, the knock-on effect of the National Care Home contract, for which all the kind of private and voluntary kind of care homes, the cost of that is a nationally set rate. So we've kind of made assumptions around that, and really importantly, the demographic impact. So the changes that we'll have kind of been expecting anyway, as a kind of an older, frailer population, but also kind of recognise an increasing impact of COVID around mental health and substance use, alcohol, etc. So try to kind of factor in all the different pressures that we think we're going to kind of be hit with over the coming years. And you can see from there that we've got an estimated kind of shortfall set out in Appendix 1 of about £25 million from next year to all the way up to 26-27. Of immediate concern is the figure in 23-24, which sees £8.6 million. So, you know, not an insignificant sum of money. And then follow that up with another £6.7 million the year after. So kind of two really challenging years ahead. And while it drops slightly for 25-26 and 26-27, still big amounts to come through for that. This is, of course, all dependent on the budget settlements and what that looks like, and any additional funding Scottish Government will provide to us. Hopeful that will come through like it has in previous years. But what kind of really focuses for us as an IJB is that challenge that we've got ahead. We've set out, you know, how we intend as an IJB to kind of tackle some of those challenges. So making sure we're getting best value across our service provision, and where we look to prioritise our investment now for kind of benefits in the future. So it goes back to what was discussed earlier around the use of reserves and how we kind of use reserves. We will also need to, in terms of our financial management, look at how much of those reserves we will have to retain to kind of offset any kind of cost pressures that or challenges that we're going to experience as well. That can only be done once though, so once the reserve's gone, it's gone. So back to the comment that we had 450,000 a couple of years ago because we had to use reserves previously to support the overall position. So the report is there for the IJB to kind of note the kind of projected position. The more detail will follow within the kind of the budget process as we as we kind of go through that with our partner bodies. Again, for newer members, we hold regular budget development sessions with the IJB, which are kind of private sessions that we take members through the various aspects of the budget at the various stages, so everybody's informed of the position. So hopefully, bad news in terms of what it looks like, but it kind of sets out the challenge for us for the coming years.
Yeah, I think it's very difficult to come up with a 5-year forecast at this point in history. And you mentioned inflation, which is now up to 9.1%, the highest in 40 years. So good luck to you, Dave. It's a difficult job that you have with all the financial uncertainty. Now, a couple of hands here. Donald McPherson's first.
Thank you, Chair, and thanks very much, Dave. I mean, it's a very clear paper, but it doesn't make the messages any easier for us to note. But I think, you know, well done for giving us the visibility around this. My question was really around, and it's section 4.1.10 of your paper, is around the transformation programme, where you list a number of projects that are already underway. And I suppose my point is really an extension of the one that I made earlier on in relation to the, you know, tracking the drug plan progress. I would, whether it's to the IJB or whether it's the Performance and Audit Committee, I'm open-minded, but I think really one or other of those bodies needs to have very clear visibility of the progress of these key projects and how they add up into the overall programme. So yeah, I think we should be seeing, I think what it needs is like a single page dashboard that shows us the status of how each of them is progressing, and with maybe just a little bit of background behind that, not delving into every single task, and I'm sure there are many of them, but just enough. We as a board can't manage these projects, but we certainly need to have oversight of them, and we need to know how well they're progressing. So that's the sort of visibility I would certainly look for particularly under those transformation items.
It's a red, amber, green type of update then.
I'm afraid so.
No, but I mean, red, amber, green is really useful.
Yeah.
I'm not sure if we use this, if I've just seen them in NHS Tayside papers, but yeah, I think, are you able to take that on board, Dave?
Yeah, no, absolutely, and kind of Donald's absolutely right. I mean, this is something that we have said that we will kind of take back and develop again. It was, I think, comments from a previous IJB, but also one of the audit comments from before as well. So now we're in that position of in terms of kind of facing that significant financial challenge, that we'll absolutely make sure that's in place throughout 22-23 for the boards to kind of be kept up to date with that position, because it is about what we do now. We can't wait until March or April to start it. We've got to do it, to start doing these things now. So happy to do that, Donald.
Thank you. Councillor McHugh.
Thank you. Yeah, you've got my vote for a traffic light system. I like a traffic light system. I've got a question on risk assessment, and it's really to aid my understanding. On page, well, it's 143 in the bundles. It's section 6, inherent risk level, likelihood, extreme. I saw the word extreme, and of course, I didn't panic, but it did jump out at me. And underneath that, mitigating actions, including timescales and resources, I don't see any timescale in what's listed there. So I really don't understand how concerned we should be about an extreme level of risk.
Yeah, so absolutely right. I mean, financial risk is one that's kind of right at the top of our strategic risk register. So again, the IJB has a strategic risk register, which is kind of shared with IJB members on a regular basis, and as member of the PAC, you'll get that's our Performance Audit Committee, you'll get regular reporting around risk and what the various risk levels are. So extreme risk is the kind of highest rating. The score's actually not the highest rating. You can get it's a 25 is the highest rating, a 5 by 5. What we're saying is obviously in terms of looking forward, there is a risk to the financial sustainability of the IJB because of those challenges. So that's the inherent risk. So if we did nothing, that's what we know. That's where the risk level would be. And then the kind of residual and planned are around the actions that we're kind of planning on taking to kind of reduce those levels. So in terms of kind of timescales, etc., in terms of mitigation actions, well, I mean, in effect, the timescales are those that are kind of set out over the 5-year plan. So it'll be through the annual budget process, almost kind of year by year, but we'll kind of we see what's ahead of us at that period of time. And in terms of the resources kind of element around that, it will be basically once we refine that a bit further in terms of what it is we're actually going to put in place. So back to the discussion around the use of reserves and how we're going to do that. That will then become clearer in terms of how much of a resource that we're going to need to kind of help us to invest, to save, etc. On that side of things. So we have got those kind of range of actions that we'll be putting in place to kind of try and reduce that from that extreme level to although still high, but certainly something that's a bit more manageable for us.
Okay, I'm a little reassured. Thank you.
Yeah. I think you're on mute again, Ken.
I'm just trying to. I think I'm on the wrong paper. I know that we are asked to do something. Sorry, it's to go to the agenda. This is the 5-year.
Yeah, here's the 5-year financial framework, page 139. If you wish, I'll read out the recommendations.
Yeah, all right, Willie, thanks.
Yeah, thanks. Integration Joint Boards asked to give the recommendation 2.1. Notes of potential financial challenges which may impact on the IJB's delegated budget over the medium to longer term as set out in sections 4.1.1 to 4.1.8 and Appendix 1 to the report. And also, finally, 2.2 is asked to approve the framework and range of principles under which the IJB will approach these challenges to ensure that IJB is able to deliver its strategic and commissioning priorities while delivering a balanced budget as set out in sections 4.1.9 and 4.1.10 of the report.
Thanks for that, Willie. Is anyone otherwise minded, as we say at council meetings? Donald's hands up.
Yeah, no, I mean, I'm happy to support the recommendations, but I wonder whether, coming back to the point that I was making, do we need an additional instruction to the chief officer to provide reporting on the progress against the transformation programme? Do we need to do that to get it fully captured as an action?
Yeah,
I would agree with that. Dave?
Yeah, I was going to say, I mean, we have kind of put it as section 4.1.10, but I think, Donald's right, we should probably kind of put that as a formal recommendation. So it's kind of picked up in the action tracker in particular. So
can that be that? Great, thank you. Next item, please.
Yeah, thanks very much, Chair. For that item have been agreed. Item 16 then before you, the Health and Social Care Partnership Workforce Plan. That's the recommendations.
Yeah, okay, so that's page 147. Here we are. Yeah, this is a really important paper referenced previously in the meeting, because it's absolutely essential that we have a realistic and robust workforce plan so that we're able to provide the services that we the people of Dundee need in terms of health and social care. So who's going to speak to this, please?
I'll introduce this, then I'll hand over to Lindsay.
Thank you.
Okay,
Hi,
so I
Lindsay.
think we've heard quite a bit about workforce today, and I think as people were saying, it's our biggest resource, but it's also equally one of our greatest challenges and probably one of greatest risks. So this is the first one that we've done in Dundee that tries to pull everything together into a single integrated workforce plan. Really, that builds on a lot of work with a group of stakeholders, and it's including professional aid services, HR, staff side, and gone through the staff side programme to get here. We have to submit this to the government for the 31st of July, but I think, as you've said, much more important that we understand what the challenges are and how we're going to tackle them going forward. So I'm going to hand over to Lindsay, who did a lot of work on the paper and the report to go through some of it.
Great stuff, thank you very much. So the plan, it follows guidance provided by the Scottish Government, which was prepared following the publication of the National Workforce Strategy for Health and Care. So we received that guidance around about March this year. So in context, and it's not new to your plan, was prepared during a period of increased demand on services and a reduction in many areas of available staffing due to COVID and non-COVID related absence and low availability of many staff groups, also exacerbated by ageing demographic and high levels of retirement as well. So as you know, the impact of the pandemic and the current pressure on staff has been profound. So when preparing the plan, we used all available local and national data to provide intelligence, particularly focused on age profiles of key staff groups, the balance of the workforce with protected characteristics, and also workforce availability. There was limitation to the depth of analysis that we could publish in this plan due to the small numbers. We really have to sort of dig deep in the data to identify variations and inequalities, and we just can't publish that data due to possibly identifying people. But we do look at that as management level data behind the scenes, and we are developing a workforce data group to take that forward. So in terms of the plan and our action plan, it sets out our current position and in relation to workforce planning, and we do acknowledge that there are areas requiring to be progressed. And it's very much the action plan is our starting point to progressing this, and we have agreed to support recruitment and retention, invest in new ways of working, develop career progression routes and support wellbeing, whilst ultimately ensuring our workforce feels valued and rewarded in the job roles that they do. Our action plan is a companion document to the plan, and at the moment is a working document at management level, as is our risk log. So we have identified, as mentioned earlier in the meeting, a number of risks in relation to our workforce, and we will continue to monitor these throughout the period of the plan. And as I said, the risk log is at management level at the moment and is a companion document in addition to the action plan. So I think that's probably all I wanted to say.
Now, maybe just tidy up a little bit of an admin oversight in the report, Chair. Our auditors pointed out that we should refer it to action plan in Appendix X, and similarly under risk, that's an administrative error. These documents are actually integrated within the report rather than appendices, but we'll tidy that up before we submit it to the government.
Okay, thank you. Sarah, would you like to come in?
Yeah, thank you very much, Chair, and thank you, Jenny and Lynn, for your efforts and endeavours. This is never an easy challenge to get a workforce plan that's integrated in such a way that you've done, so thank you very much for that. The only thing that I was thinking from a healthcare professional's perspective is that I couldn't just see mention and note of the Health and Care Staff in Scotland Act. And you'll remember that this was passed in law by Scottish ministers prior to the pandemic. The work on the guidance to implement the Act has now started to recommence. So this will be vital in order to support workload and workforce planning going forward. So it was maybe just something that would be helpful to mention in your plan before remittance to the government. Thank you.
Do that.
Donald.
Thank you, Chair. Thanks very much for the paper. It's a lot of useful information in there and good, and I think it sets out the scale of the challenge. I mean, I had 2 points, if I may. I mean, the first was bearing in mind that, of course, the IJB doesn't, the Health and Social Care Partnership doesn't employ people. They're employees of NHS Tayside on the one hand, or Dundee City Council on the other hand. The question for me was, what are the things that we can actually do to influence any of the issues that you set out in the paper? So that was my first question. My second one was I wanted to push back a little bit on this point about information on the reason for people leaving posts. I mean, that is really important to us. I mean, we talk a lot about attracting new people in, but just as important is that we do everything we possibly can to retain the people who are already there. And part of that must be us knowing why people are leaving. And I know there's the issue about not reporting less than 5 individually, but if I'm looking at a list of 243 leavers from NHS Tayside and Dundee City Council 103, so almost 350 people leaving over the last year, that's an awful lot of individual reasons before each of them takes them down below the 5 level. So I'm not convinced by the argument. I think I would like us to have more visibility around the reasons why people are leaving, while of course respecting the confidentiality point. So those were my 2 points. I noticed Jenny's hands come up, so maybe on the same issue that I was raising, but thank you.
Yep, actually, can I bring in Vicky? Did you want to comment at this point?
Yeah, sorry, it was specifically on that, and I see that Jenny's gonna come back as well. And really just to say, I totally agree with your level of concern, Donald, and we've done quite a considerable amount of work to understand, not necessarily just in terms of exit interviews, but prior to that, when it becomes apparent that we've got staff who are considering leaving, trying to understand exactly what the dynamics are that might result in that. And I think it's fair to say that we do have concerns across the workforce, but also in particular areas, and Jenny might give a wee bit more detail about that, about the number of people who are deciding to leave, whether that's in kind of earlier than usual retirement, or whether it's actually to leave to pursue a different career. And I think it's fair to say that we think quite a large proportion of that is really as a casualty of the experience we've just all been through over the last 2 years in responding to COVID. We've done a huge amount in terms of staff health and well-being. We've done quite a lot of regular surveys. We've done quite a lot to give support, which is available either remotely or directly to staff. But we acknowledge that despite all of that, there will be an impact of the last couple of years on some staffing groups, and that some will just be choosing that they wish to have a different professional life and an alternative to that. So I totally agree with your comments about having success in recruitment is one thing, but if we can't actually have a range of jobs that are fulfilling and that people feel safe and secure in and contented, and happiness is incredibly important at work, then recruiting is really just almost a kind of revolving door in that respect. So we have lots and lots of work to do to fully understand what it feels like to undertake many of these roles and to make this a much more fulfilling and healthier workplace for all. But I'm sure Jenny might talk about some specifics, because there are some areas where we're seeing a much higher turnover rate than we would have pre-pandemic.
If you're not speaking, can everyone turn off the mic? I'm hearing what sounds like rock coming through my speaker.
I think it's whoever is dialed in on their mobile phone. They're not muted, so perhaps if they could mute, it might be easier. Thanks.
Yeah.
I'm glad that wasn't me. Yeah, it's everything that Vicky said, but I take on board the point, Donald, and we'll have a look at whether we can aggregate that up and present it a bit differently next time to look at some of the themes. We do have particular issues in that we know that our social care workforce, particularly in care homes, have been really traumatised by the experience. So that's a particular hotspot, and all the issues that we've noted nationally in relation to that. So we are doing some specific bits of work around that. In relation to your point, though, about how much control we have over this is part of a complicated picture in terms of workforce planning. So we feed into both the bigger systems in the council and the NHS in terms of workforce planning and submit this to the government. So there's actions at multiple levels. Some of it sits nationally in terms of training enough people in particular roles. And us feeding in what our needs are helps that process. Similarly, we link into workforce groups in the NHS and the council, and some of the actions sit with them. I think some things are within our control, so that particularly the work that we're doing around wellbeing, around recruitment, around making, you know, more rewarding roles for staff, some of the fair work stuff that we've been doing in relation to commission providers and things. So it's a combination of those three levels, I would say. It's tricky, it's not easy.
Lindsay, did you want to come in again on that particular point?
Thank you. It was just regarding the data and the levels of data that the report. So I've taken that on board absolutely, and we'll look at it again to see if we could split it up a little bit more to be a little bit more transparent in how we report. But certainly we do look at that behind the scenes, and it's something we do see is very important to be acknowledging and feeding into the plan. And as we move forward with our partners, employers, where we could improve our data sets and our reporting consistently across the three Tayside partnerships and NHS Tayside, it will become easier for us to do that. So absolutely, it's on the agenda, and we are taking that forward.
Okay, next up I have Jenny, followed by Councillor Toland, and then we'll have to wind this item down because its time is going on. Jenny, you first then.
Yeah, thanks. It's just following on from Donald's point. I think it would be actually good. I mean, not that I'm going to be at all the IJBs, but I think it would be good to actually include somewhere in the report about your exit interviews. So, I mean, and again, I know that it's complicated, but if you're employed by NHS Tayside, you should be getting an exit interview. But I take on board Vicky's point as well, and I've always said it, that before you get to the exit interview, when the member of staff is actually talking about resigning, that's when the discussions should start taking place. So that we see, and I would also like a bit where you're seeing in your report, and I can't find the page now, but I've seen in your report that you're going to be doing something about helping the staff who are carers. Well, NHS staff are all governed under the PIN policies. So you've got all your family friendly policies there. So that might be something else that should be in the report, that you adhere to the staff governance standards.
Thanks, that's helpful feedback. We'll take that on board.
And last but not least, Councillor Toland.
Thank you. I'm just picking up on something that Jenny had mentioned, and I noticed that myself, that the extraordinarily high levels of trauma and potential PTSD among the workforce, and particularly amongst the kind of social care sector. You said that there was a few initiatives, Jenny, in trying to address that. Can you maybe explain what those might be, and how you think we might move forward that? Because that's I found that a particularly disturbing figure, I'm going to be honest.
I think it was, and it was striking how much worse the impact had been on social care staff versus NHS staff. So that it's really a quite detailed wellbeing framework that we've been offering to staff and actively encouraging people, and that takes you right through from kind of self-help materials to more targeted interventions with teams where they would work with somebody around wellbeing, right through to very kind of specialist input where people are particularly traumatised. A lot of work to just identify how to get that to staff, so things like taking it to staff rather than expecting staff to seek it out themselves and things like that. So I mean, anybody and everybody really, the listening service, the psychology service, it's really as detailed as we can get it with as many different types of input.
Thanks. And have you any idea when the Strathclyde and Kinsey Institute report's going to come out?
I thought it was out, but I will check.
It's just it said in the report that it was due to come out, so I wasn't quite sure. Okay, thank you.
I did say no one else, but I'll take Jim McFarlane, and that's definitely it.
Yeah, sorry, I was just when
Sorry.
Councillor in particular mentioned the issue around the trauma, particularly for social care staff, and it is something that we need to grapple with around it. And I know it's something we've discussed in the councils because there's been wellbeing support, staff support available, but in particular, this staff group has been the one who've been the least likely to take up what's been offered. And I know it's something we've tried to, work together on trying to encourage people to do that, about freeing up people, about people actually seeing it being relevant to them and stuff like that. And that's clearly, that's going to have to be an ongoing piece of work on that, about people, people seeing the value of it and making sure that it is something for them, because speaking to too many people who work in social care, they just think, well, either I've not got the time to go and do that because I'm too busy, or they're getting the mixed message around getting freed up to about what's available and stuff like that. So yeah, welcome the discussion on it. I think they should take that forward.
We're in early discussions with the listening service about them possibly going into care homes, but we think part of what it is they're so well established within the NHS that people get it word of mouth, they know about it. So it is, as you say, Jim, it's that proactive approach to trying to get it in there rather than expecting staff to kind of seek that out.
I think what's been made clear during the discussion on this paper is not only is it do we face severe challenges recruiting people to work in health and social care, but we have faced challenges in our staff who are in post buckling under the pressure and leaving. So it's a double whammy, and one which we must address. Did we agree something on exit interviews that needs to be is it noted in the minute, Willie? That we'll be getting more information on that. I'll check with Willie afterwards if he's maybe lost a connection or something. But I think it's important that we're on the ball with knowing how the staff who are in post and think they're leaving feel, and those who actually take that final step and leave. It's important that we know why, so that we can learn lessons from that and provide better support. So we're asked to accept the recommendations at 2.1 and 2.2. Is that agreed? Thank you. If Willie's not here, it'll be down to me to find the next item. Are you not here, Willie? No, he's not. Can everyone hear me? Yeah.
Yeah.
So that was the workforce plan. So we're now on to the Carers Investment Plan, item 17, page 151, which is, this is an update on Carers Investment Plan as it says. Who would like to speak to this?
So I'm going to speak to that. This is really a report bringing back a revised investment plan. So we brought it back as far as we had it to the last one, and I apologise for how complicated the finance is getting to this. And then we agreed we'd bring back more detail around the future investment plan this time. So it's a combination of things that we've mainstreamed, things we agreed the last time, and things that we're putting forward this time for agreement that are detailed in the appendix, and that gives you the full total of the investment, which is now standing at 2.151 million. A lot of work being done through the Carers Partnership over the past few years to look at our gaps, to look at our strategy, and we've presented a Caring Dundee 2. And this is the kind of outcome of that, in that we've taken a preventative approach that's nationally recognised, and Lucinda was in fact presenting that at the government the other day. But we've now got a kind of group of people that are caring for people with more complex needs, who have needs themselves, who may be caring for people with multiple people. And we know that there's been this gap around the uptake of adult carers support plans. So we've put forward a number of proposals around this. 240,000 to support carers, well, to increase the identification and support provided through our social work teams, additional respite capacity for carers, some money to support the implementation, and that's really about ensuring that practice is good around this, as well as building the operational capacity, and that we work through some quite complicated issues in terms of contracting and things like that to increase the uptake of SDS. And also some monies that we're looking for around the digital support worker to improve communication and kind of information for carers. So we're really looking for that investment plan to be agreed, and I'm hoping that what we will then do next year is come back with how we're mainstreaming all of this, and that'll be the final complicated financial bit of the Carers Act.
Thank you for that. Martin, would you like to come in, please?
Yes, just very briefly, due to the time constraint, just want to say that I welcome the investment plan in its entirety. It's good to see that carers are going to be invested in a wide area, and hopefully the monies that are set aside for care identification and for just general operations will really improve the lives of carers across the city. And Willie is still on the meeting, just muted his phone.
Thanks.
He's muted his phone, but surely he would have heard me. Confused now. Anyway, not to worry. Councillor McHugh.
Thank you. Looking at your table, page number 158, I see there's a reduction of 28,000 under streamlining breaks for carers. Could someone comment on that, please?
Yeah, well, we'd put forward an initial proposal last year, and I suppose what we've done this year is refined it. So it's not actually a reduction, it's things that have been rejigged about and put in different places to confirm the investment we actually want, as opposed to what we thought we needed last year.
Right, I'll try to digest that. Could I just make one comment? In the last column in your table, it says it's headed comments rationale. Okay, so when you say rationale, the comments contained in that column, the rationale for what? For the service being provided.
Yeah.
I'm just trying to understand, opposite that, what looks to me like a reduction for breaks. It says increase carer outcomes through accessing a break, including well-being and being able to manage their caring role. I don't actually know what that means.
So this is the work that's done through the Carers Centre, that carers who need a break can apply for funding to have whatever will support them to have a break. So that could really be anything that will meet their outcomes. And the shift in that is recognising that some people where there's complex needs, having a break will involve some degree of replacement care. And so we need to have things like the respite investment and the ability to waive charges for more complex needs. So it's not an overall reduction in how we support carers to have a break. It's just a kind of rejig of making sure that all carers with different types of needs are covered in that.
Okay, and just to aid my understanding, the column headed comments rationale, the rationale that is described there is the rationale for the service.
Yes, not the change.
Not the rationale for the change. I found that quite confusing because what we're looking at are changes over time, And I think it would be more useful to have the rationale of the change, to describe the change.
Yep.
That's just me, I'm a process person, you know.
No, that's helpful. We'll take that on board and do that next time. Thank you.
You've just joined us, Dorothy, and you want to change everything. But I think
That's me though, Ken. That's me.
That's a positive change, so I think Jenny's happy with that, and if it makes things more clear for everyone, that's a good thing. I see no other hands, so can we agree the recommendations, one of which at 2.2 remits the Chief Officer to issue directions set out at section 8. Are we happy with that? Yep, great stuff, thank you. I think we're on the home straight now, otherwise I'll have to call another brief recess. Let me just check the agenda. I thought it was going to be a bit shorter today, but not to worry. It's important that we discuss everything fully.
On to item 18, Chair.
18, yeah. Which is the annual report of the Dundee Health and Social Care Partnership, Clinical Care and Professional Governance Group, which is page 161. Anyone like to...
Matthew will introduce this.
Yeah.
Matthew will introduce it, Ken.
Yep. Hi, Matthew.
Hi, thank you, Ken. So this is the annual report for the Clinical Care Professional Governance. The recommendations are to note the content of the report and note the work undertaken by the partnership in and around professional governance from April 21 to March 22. I'll just pull out some of the key headings, but certainly don't intend to go through this in a lot of depth, and we'll open to questions at the end. So the objects and the responsibilities of our governance are the review and inquiry about risks being managed across the Dundee Partnership and the actions progressed to mitigate those risks. We also have the review and inquiry to demonstrate that there are systems to embed clinical care and professional governance at all levels, from frontline staff to the IJB, and to drive a culture of continuous improvement. We also seek to share the learning from best practice, and innovative ways of working in relation to clinical care professional governance. Our group, the Clinical Care Professional Governance Group, plan to meet on 6 occasions this year at section 4.2.3. We had to cancel the session in September due to the significant pressures of COVID with the Omicron variant at that time. But in January, we had an exceptions-only meeting with senior leadership teams to make sure that we had meetings and discussed the key areas of concern. I've included within the report the dates below, which are our Clinical Care Professional Governance Forum, which is a lower level group, but they met on 6 occasions. And that's just to provide a degree of assurance that teams and services were meeting, were having conversations about governance, and were able to provide quite a bit of assurance through our professional leads who span both the forum and the group. So the levels of assurance could still be provided. Assurance reports are provided to a range of committees across the board, in particular the Care Governance Committee, the Performance and Audit Committee, and these assurance reports were provided in the dates listed there from June 21 through to April 22. The next section there, which is titled Dundee Health and Social Care Partnerships Governance Structures, it starts with the diagram of the pyramid. That goes into a fair bit of detail about the structures that we've implemented and put into place prior to the pandemic, but through the course of the pandemic as well. I won't talk to that in any real depth, but just to say that the lower part of that pyramid is our forum, which is very much an educational forum, where we ask service managers to come and they provide assurance on the reports, but also receive education on how to manage clinical care and professional governance as well as they can across the partnership. The primary governance groups, the next level up, is the area where our main level of assurance is provided and operational governance within the partnership. We have 9 primary governance groups, and underneath them there are a whole host of different arrangements for individual services and professions. Each primary governance group will report into our clinical care and professional governance group, which is the main group within the partnership that receives assurance and then provides that assurance onward to the IJB, PAC and the Care Governance Committee. You'll see that mental health sits to the side of that. Mental health are very good in terms of working with our partners in the other partnerships, also our inpatient colleagues, and they've got a quality performance review. So we feed into that and that feeds back into our group. So there's good governance from the whole system in terms of mental health. Coming at the side of the pyramid there, we've got a huddle. This is a small professional group that meet weekly, and they review in particular the incidents and the risks, really to try and make sure that we've got an early warning system in place, so that if things are starting to change or we notice areas of particular concern, we can support the teams in terms of managing that. So I won't talk to sort of the rest of the explanations necessarily in there, but I'm moving down to the summary assurance statement. So certainly this year has been one of the most challenging across the health and social care system, clearly because of the pandemic. However, I do think it's worth noting, and it's come up a number of times today, that our response from staff has been incredible and has supported the continued delivery of high quality and safe services. I do think that we need to recognise that in extremely difficult times. As we move forward, learning and the sharing of learning does remain a key focus within the partnership. And while this has developed well over the year, it does remain an area where we feel further improvements will be made. And we think that that's important in terms of moving towards more substantial levels of assurance. And that's defined as a sound system of governance, risk management and control exists, with internal controls operating effectively and being consistently applied to support the achievement of objectives in the area audited, where controls are applied continuously or with only minor lapses. We have, for every report that we've put through to the PAC and the Care Governance Committee, we've had reasonable levels of assurance throughout this year. In order to move, we feel that the issues that we need to address are more timely management of some of our administration around risks, complaints and adverse events. And as has been mentioned many times through this meeting today, the ongoing workforce availability and the challenges with recruiting staff, retaining staff and supporting staff to be able to deliver the work that they're employed to do. There is some evidence of non-compliance, which I think will support us in moving to those substantial levels of assurance from reasonable levels of assurance. And that's really just around attendance at all governance groups for all teams and providing reports every time. So that is extremely challenging at this point in time. And I feel that actually, considering all of the challenges, the teams have done exceptionally well in providing that. Section 4.3, which I'm not going to go through, really just details the work for each of the meetings that we've had this year. And members may recognise some of those topics that maybe came through the individual governance reports that have been written through the course of the year. And the final comment really down at section 4.4, the assurance statement. And I note that David Shaw, our Associate Medical Director, is with us, but he certainly has said that he's satisfied with the integrated approach, the frequency of meetings, the breadth of the business undertaken, and the range of attendees at the meetings, which has supported the fulfilment of the group's objectives and responsibilities. And again, wants to provide thanks to the commitment and dedication of fellow members who have supported the work around governance and also the pulling together of the reports and the meetings. So I'll pause there. I don't know if David or Diane want to add anything to that.
Just to say, it has, as Matthew said, been a very difficult year, and I think it shows the dedication of our staff that despite those challenges, they have still sought to ensure that governance was at the heart of everything they were doing. We have certainly had some very difficult conversations, and we have needed to escalate such areas as the challenges within the DDR service. And I think that we do have a good mechanism for identifying where there are governance concerns and doing something productive with that. We've obviously got a little bit more to go, but I think certainly a good trajectory during a very difficult time.
Yeah, it's reassuring to know. Are there any questions for Matthew? No, well, thank you for speaking to the report. Matthew, we're asked to accept the recommendations at 2.1 and 2.2. I see no dissent, so thanks very much. And I think we're on to the final agenda item now.
That's right, Chair. Item 19, annual complaints performance. You have a report before you.
Okay, that's page
173, Chair. I'll take you through this one. Claire Lewis-Robertson would normally go through this one. She's on leave this week. So yeah, we do have before you the annual complaints performance report. The complaints are reported to kind of Performance and Audit Committee on a regular basis as well. So again, it's one of the suite of reports that will go. This is the annual report being brought back to the IJB for oversight. in terms of a lot of kind of what Matthew's just described in terms of the clinical care professional governance, a lot of the complaints, that information that's going to shared in here is going to shared within the throughout the year within that particular forum as well. And you can see from the kind of performance in terms of where we're at as a health and social care partnership and kind of responding to complaints. And what we do with them, because that's probably the kind of most important thing, is how we stop that these sort of things happening again. So so kind of probably the main highlights there is the number of complaints are probably starting to kind of rise back to the level we would have seen kind of pre-pandemic. 217 complaints for our delegated services received over 21-22. Most kind of in terms of the highest proportion, the kind of mental health and kind of challenges around kind of mental health services are the kind of highest kind of specific area where the complaints come from. And the kind of report goes on to kind of talk about the kind of performance in terms of kind of closing complaints and kind of coming to a resolution against each of those. Noted that the information that's presented today is probably slightly different from what was kind of previously experienced, because the Public Services Ombudsman has new standards for complaints and reporting, so we've kind of standardised that a lot to kind of meet to comply with the SPSO's kind of processes and requirements. One element I'll just kind of give a verbal update around, because it should have been kind of picked up in the report. It was from a previous comment made in a sort of previous report, was around kind of context. So the kind of section 4.7, we talk about the percentage of complaints and outcomes at each of the stages in terms of stage 1 and kind of frontline resolution, stage 2 where there's an investigation, and then stage 3 where it's kind of escalated to the SPSO itself. So in terms of numbers rather than percentages, so just kind of in terms of stage 1, there were 21 complaints that were upheld, 21 were partially upheld, and 22 of those were not upheld. In terms of stage 2, 19 were upheld, 104 were partially upheld, and 60 were not upheld. And in terms of escalation to past stage 2, 4 were upheld, 9 were partially upheld, and 11 were not upheld. So so that kind of gives the context in terms of the kind of numbers there behind the percentages, if you like. So happy to take any questions or observations on that one.
Yep. First up is Dorothy.
Thank you. And I'll try not to hold you up for too long. I just don't understand the tables on page 175 at 4.7. I don't understand where the totals come from. When I see a table, I want to add it up or subtract it or, do something mathematical with it. And I don't know how these figures, in the first column, upheld 20%, social work 20%, health 31%, total 27%. Where does that come from?
Yeah, so to be fair, Councillor, I did ask the same question. Obviously, being an accountant, I'm the same. I like to see kind of numbers that kind of all balance off. It's to do with the actual kind of, that's the kind of average kind of total, because you're working with percentages, so it's kind of to do with.
I thought it was an average. Yes,
yeah, so it's an average percentage that's used there, and I think that's one of the ones that, again, Scottish Public Ombudsman asks us to report on that basis. So it's not particularly clear. What we'll do in future is we'll make sure the numbers are actually there, rather than just the percentages, because I think that is causing a bit of confusion.
Or even if that was changed to say average, I mean, that would make sense. I mean, in the next column, it's the same. The numbers don't kind of mean much, or the percentages don't. What is the total in the next column? Complaint outcomes at stage 2.
Yeah, so it's exactly the same. Exactly the
That's
same.
an average. These are averages.
They've all been done on the same basis. All those tables on section 4.7. So yeah, happy to take that back for a
And 4.8 as well.
change in features.
4.8 as well. Average time in working days, 15.6, total 9.
That's incomprehensible. You're absolutely right.
Yeah. Okay. No, that's fine. We'll take that back and look at that for future reporting.
Thank you very much.
It is important we have accurate data on complaints. But yeah, thanks for bringing that up, Dorothy. Sarah, would you like to come in at this point?
Yes, please, Chair. Thank you, and thanks very much, Dave, for your report. Initial observation, and then I've got a couple of questions, please. So, observation-wise, it's really pleasing to see that we're putting complaints, feedback at the heart of governance arrangements across the IJB. And whilst I can see evidence of the performance measures by which we'll need to report to comply with the Scottish Public Services Ombudsman requirement, I'd like to see an increased focus on the quality aspects of that. So my questions are around, firstly, would it be possible to include those complaints where early intervention has resolved them? So they don't go to a stage 1 or a stage 2, it's the early intervention resolve. My second question is around compliments. So this is compliments, comments and complaints. So what I'm not seeing is the balance of the feedback that teams who work tirelessly across our system may have received that is complementary of the services, rather than the focus being purely on those aspects that might not have gone as well. And my third point of question is, could we see inclusion of the work that is being done around the use of the care opinion platform? Because again, that gives balance and feedback in a very timely way for people in a much more transparent process. Thank you.
Thank you, Martin.
Sorry, can I just have a response to a couple of the questions first, Chair? Thank you.
This meeting has the chair's flagging a bit, I have to say. Yeah, could you respond to that, Dave? Sorry.
Yeah, certainly. So in terms of the early intervention, I think that's how that's recorded, because the early intervention is almost like before the complaint actually then arrives, which I don't think is recorded anywhere. Stage 1 is the first time that somebody says, I've got an issue or a kind of a concern to be raised. So that is the stage 1. Pre that, I don't know how we would kind of manage to record that. I suppose it's back to, I suppose kind of linking in with some of your other aspects about quality and how services are provided. And they're certainly, clinical care and professional governance, that's that is a feature of that, those discussions. In terms of the kind of compliments as well, I think that's a fair point. Again, I know that compliments are gathered and kind of positive feedback is gathered. So we certainly kind of look to incorporate a complaints and compliments kind of report in future. So happy to kind of take that one forward. And similarly, in terms of the care opinion platform, I'm aware of it. I'm not too familiar with that, so I need to kind of check with Claire and others technically how we can kind of take information from that and kind of pull that through. But certainly kind of worth exploring as well, Sarah. So thanks for those points.
Thank you very much, Dave. Just in terms of early intervention, it was more a thought around in adopting a learning culture approach as part of embedding governance. It may be just some examples of where things have been able to be resolved at a team or in a person's home or at an interface level with people. So it might be just more examples rather than a performance measure of it. Thank you. Thanks.
Thank you, Sarah. What you were saying about compliments, I think we started doing that at Dundee City Council a number of years ago, recording and bringing it to committee compliments. So yeah, it'd be useful to hear that side of the equation as well as the complaints. Martin?
Thanks, Chair. Just to follow up on the comment that Dorothy made earlier, would it not be a good idea to bring a revised set of data to the next Performance and Audit Committee, so that members who attend that also get a chance to see what the actual data behind the the slightly confusing data that was presented today?
Yeah, so I'll again certainly take that back for us to kind of have a look at and see what we can do. Next performance audit committee is in probably about a month's time, actually, in terms of kind of later July. So we'll see what we can turn around in that time. Martin, thanks.
Is that a commitment then, or a maybe?
Given it's not myself that does it, I need to kind of just double check and make sure that can be done, given annual leave commitments and things like that. But yeah, Willie will have it down as an action, as Dave will. I know he will, so it's fine.
Right. So I think that's the end of this item, which we are asked to note. Thank you. And we now move on to our final item, which is a record of attendance, which is for noting, followed by the programme of meetings, which I look forward to seeing everyone at. And finally, Donald.
Just a quick question to ask whether there's any contemplation of going back to either physical or hybrid meetings for the IJB. Certainly the other IJB that I sit on is now going to hybrid from its meeting next week. I just wonder whether we have thoughts in the same way.
I haven't had any discussions on. Vicky, would you like to come in here?
Yeah, I think it's probably still under consideration. It's probably the only update I can give. A lot of it, particularly a hybrid option, which I think would be favoured in terms of still securing input into the IJB for those who can't attend in person, is dependent on the facilities that we have got available to us and the technology. So clearly, there are other parts of Tayside, including the NHS board, where they've got a facility where a small number of people can attend in person in a room, but with a large enough kit and screens to be able to include other people in virtually. But we're still working through a programme to see exactly what access we would have to that type of facility to enable that to happen. I think ultimately, feedback we've had from a number of people is that they would like us to work towards a hybrid model, but I think we're some way off that at this point. Yeah,
certainly. I'd like to see that hybrid model at the least, rather than everyone in the same room, because for people who find it difficult to attend, that's a good thing. Vicky, your hand's still up, but it's legacy. I don't think there's anyone else, is there? Yeah, so it's just onto the date and time of the next meeting, which will, at this point in time, almost certainly be online on Wednesday, 24th August at 10 o'clock in the morning. Martin?
Very briefly, sorry, very briefly, is there any indication whether we're going to have a new service user rep in place? Because I know we've been with that one now for several meetings.
Yeah, that's true. Does anyone?
I'm not too sure where that's at. I think the request has gone in, but we'll need to kind of follow that one up as well, Martin. I'll pick that up with Willie as well.
Yeah, thanks for bringing that up, Martin. And with that's all the business. So thanks for your virtual attendance, and bye for now.
Thank you.
Thank you.
Bye.